always promise you and keep up our educational activity in GIS. This time we've changed it to virtual, just to have the commitment of a GIS to all our audience, and to keep up with our education and the needs that we see in our region and demand from our audience. GIS is heavily involved with a lot of activity all over the year. And I think last year we exceed almost 8,000 people attending with us in multiple activity of GIS, from GIS CVB, GIS CompEdge, GIS Valve, and annual meeting. Also, we have under GIS Research Academy that has a lot of papers, almost 14 consensus from our region as the Gulf in the pipeline. Most of them are ready for publication. So we are busy, and the reason for that is just to meet the needs from our region and to engage with our community. Today is a special edition of GIS CompEdge after the great success that we have from previous edition. Last year we have it in Bahrain physical, and was one of the most successful edition, combining GIS communication and GIS imaging and physiology, having 6 course organizing this program from different parts of the Gulf countries, from GIS communication, Dr. Abdullah Shihab, Dr. Musa Akbar, and Dr. Khalid bin Thani, from GIS physiology and imaging, Dr. Hussam Noor, Dr. Fawaz Bardouli, and Dr. Rad Al-Qudshan. All of them did a great job, and for this success, we continue with the 7 physical in Bahrain. Today we have this edition, 5th edition, have a lot of registration. If you go to the next slides. We have more than 530 so far registered with us in this edition. More than 4 sessions will talk about the complication, great presentation, and cases, and great program. Next. Don't want to take a lot of time, but I'm here just to make an introduction. But this program have been done by our course organizer. I mentioned them, Dr. Abdullah Shihab, Dr. Musa Akbar, Dr. Khalid bin Thani, and a faculty of GIS Communication and CompEdge. They did a great job, and with this, I welcome you all to this virtual edition of GIS, and I'll leave the mic to Prof. Abdullah Shihab. Thank you very much.
Until next year, and we want to be in front of everyone, and alhamdulillah, we are in front of many things. Complication, I think, is most exciting aspect on intervention. It's not what happened at the end, it's really the judgment, and that's what we're going to learn tonight, inshallah, from everyone's here. So today I'd like to welcome our new course director to this, Khalid Thani, joined us, been doing me and Musa Akbar for the last 5 years. So inshallah, with the 3 moderators here, great Dr. Musa Akbar and Khalid bin Thani, and we have a great panelist here. We're going to go through this meeting, and I'd like everyone here, the panelists, to keep their questions and comments concise and practical, as well as audience. So we're going to tackle everything together, inshallah. Khalid bin Thani, Musa Akbar, your words, and so we can start the meeting.
Good evening, everybody. Thank you very much, Abdullah, for this brief introduction, and Dr. Fawaz for the introduction. Really proud to be for the 5th year in a row to do this program together with my colleague, Dr. Abdullah Shihab, and the recent joiner is Dr. Khalid bin Thani. We hope that you will like it, and we decided to do virtually because we're supposed to do it last May, but because of the circumstances in the region, we postponed it till next year in Bahrain, inshallah, after Eid. I would like to introduce the panelists with us today. Will be with us for the most of the time. Dr. Hadi Buhantash is a consultant interventional cardiologist from Amman, Jordan. He is with us as a panelist, as well as Dr. Misbah Firdos from BJ, China. Late in BJ, would like to welcome the panelists will be with us for the discussion and comment on each topic and each cases. And then I hope you will enjoy it. And please, if you have any question, you can post it in a QA box. We will handle them during the discussion whenever we have enough time to handle these questions. Now I will just handle to Khalid if he wants to add anything before we start program. Khalid.
Thank you all for attending this great course and conference. I hope you enjoy it. I know. I hope you are not late for the conference itself. You're gonna enjoy the topics. Great topics today to discuss. A great speaker also joining us, and I hope we get all the benefit from this conference for our daily practice. Back to you, Dr. Abdallah.
Outstanding. Thank you very much. Let's go to the business, guys. Dr. Muhannad, all of you know, professor of cardiology, and we put him really for preparation because he does all the complex things I've ever seen. So he got lots of titles. So I don't want to mention them all. It's there, professor of intervention cardiology, behind lots of CTO technique and things, and he will tell us about the coronary perforation. And we're going to hear that as a record, then we're going to discuss that matter, inshallah. So remember, what happened, why happened, and what we learned from it. Let's start.
Hello, everyone, and welcome to Newcastle. I'm Professor Muhannad Igred, consultant interventional cardiologist and structural cardiologist at the Freeman Hospital, Newcastle upon Tyne. And I'm grateful for the organizing committee for the invitation to participate in this great meeting. My task to you today is to talk about coronary perforation management. These are my conflict of interest. What I'm going to be talking about to you about the definition, the incidence, the predictors, mechanism, classification, and management. There's a lot of things to go through. But before I go to coronary perforation, a quick word about complication in general. We know that when we are doing procedure, you are going to have complication no matter what. You need to be in control. You need to be meticulous and very careful because any little details make a difference on the long term. You be prepared. You have a plan for every patient, and you need to know your patient as well as your equipment. No cutting corner, and you need to know your ability and limits because that's the most important part of doing any procedure. Similarly, when the complications happen, you do not need to be in denial. You have to own it. You stay calm and to be the leader in the cath lab. Clear instruction, consider the worst case scenario and work that way so you can be very meticulous. And of course, there's no shame in calling for help. If you need help, call your colleagues. There's always somebody there to support you. And unfortunately, complications are going to happen. They are an inevitable part of practice. So we should always learn from them, and we should work to avoid letting them deter us from providing subsequent care. So you always have to get better all the time. So really, when you're doing any procedure, you need to be prepared. What can go wrong with any case I'm doing? Do I have the technical expertise to deal with any specific complication? Similarly, do I have a strong support team? Does my institution have the capability to deal with these complications should they occur? If not, you could always refer somewhere else. And of course, in particular for coronary perforation, the presence of coils, covered stents, speed, all the equipment that need to tackle these perforation have to be present. In order to prevent this, you have to always do, when there's a balloon rupture, when there's a high pressure balloon inflation, when you use rotablation, IVL, orbital atherectomy, always make a little test before you remove your balloon. Because if there's a perforation, you could always seal it immediately with balloon and deal with it later. And of course, once you've done any complication, and complication analysis is quite important. And these are in front of you. I'm not going to go through them in details. This is a completely different talk, but nonetheless, it's the petal where you analyze it, you learn from it, you see what you've done and what you have learned for the future. Let's go back now to perforation. You've all have seen this probably, and perforation can be different. It is the extravasation from the coronary artery during or following PCI. And of course, the incidence of perforation is quite rare, although in one of the studies, CTO study was up to 8.8. Usually it's reported between 0.2 to 0.9. And of course, perforation can be associated with high in-hospital mortality, as well as late MACE, and can lead to tamponade and even death if not tackled, kind of managed immediately. There are some predictors, of course. Some of them related to the patient, some of them related to the equipment. And of course, I put the operator in red because we always invariably sometimes cutting corner or doing something incorrect can lead to a problem. The clinical indication, calcification, is one of the most significant one that leads to perforation. Of course, we're dealing with older patient, complex disease, lots of disease, so that's quite important. Chronic total occlusion is another one in age. There's some other study shows you female hypertension and ACS are related to this. As for the devices and the procedure, any ablation device like orbital atherectomy, rotablation, IVL, they all lead to this, of oversized devices and hydrophilic wires. Of course, with CTO use stiff wires, these could easily exit the artery and cause a problem. And of course, in order to understand the perforation, there is different classification. The first one depends on the location, whether it's the proximal large vessel, distal vessel, or collateral perforation in CTOs. The other classification is morphologic, and you would be familiar with this. The Ellis classification came years ago and still being used. Type 1, 2, 3, and 3 with cavity. The 1 and 2 could be easily managed conservatively and often no consequences. Anything else can be quite significant and needs handling in the cath lab. And of course, the other classification, which is important, as we said, proximal versus distal, but also if there's a pericardium or a post-cardiotomy, like post-bypass operation, can lead to localized perfusion, which can be difficult to treat percutaneously because the myocardium is stripped and becomes in pocket loculated perfusion. And of course, also whether there's a wire across the artery or you have removed your wire and to have the to wire the artery again. That takes more time and can be more difficult to manage. So what are the management steps, which are the most important thing? The first thing, it is a hole in the artery. So what you need to do is just a balloon tamponade this artery. Once you put the balloon in and inflated it, that's it. You could stop, you could assess, and you're in control. And of course, at this time, you need to see, is the patient hemodynamically compromised or not? Is there any pericardial effusion that I need to take care of? And then you could decide what you need to do. So of course, the pericardiocentesis is important. If the patient is hemocompromised, you start some fluid. There's at the end here is reversal of anticoagulation. This is the last thing you want to do, and I'll explain that in a minute. Of course, once you've tamponaded the artery, when you have your time to control the extravasation and the bleed, you could stop and make sure that you're following the correct steps to make sure that you handle this in the right way. And this is in general how this happens. Immediate balloon inflation. As I said, this is a hole where the blood is leaking from. Put the balloon up, inflate the balloon, and that stops the blood from leaking. Then you're in control and you can do anything you want. You start IV fluid and support, you assess with the echo. And sometimes even without echo, there's a small picture here on the left, where you could see the pericardium full of contrast, because that's what happens. There's a perforation. When you inject the contrast, it's going to go to the pericardium. So you could see it. And if you need to do an emergency pericardiocentesis, if the echo machine is not available, this helps you quite a lot. And the second thing, if the extravasation has stopped, fine. We monitor the patient and we repeat the echo, we keep them under control or under observation, because up to 8 hours, things could still go wrong. If there's still persistent extravasation, what do you do? In large proximal vessels, there's a covered stent. There's not many ways. Sometimes inflating the balloon itself can seal this, but if that's not the case, covered stents are the only answer. In distal vessel perforation, covered stents don't help. So you ended up having to block the artery by coiling it, by using fat, by using thrombus. And we have published something about using a balloon remnant, i.e. cut the balloon and deliver it to the distal part of the artery. And this is becoming a quite common practice, and I've seen it many times right now. In collateral perforation is a little bit more complex when you're doing CTOs, where you might have to coil the collateral from both directions, antegrade and retrograde. And often these measures nowadays are very successful and hardly ever end up with the patient sent for surgery. But of course, if this does not work, then you might have to consider surgery. I put the top right there, do not reverse heparin. The number of times when you ask people in any meeting, what do you do when the perforation happens? Give protamine, reverse heparin. Absolutely not. If any message you take from this today, just remember, you do not reverse the heparin until you sorted the problem out. It's a mechanical problem with the hole in the artery. Reversing the heparin is not going to do anything. And if you are continuing to have equipment inside the artery, the next thing is going to happen is thrombosis becomes a much bigger problem. So please do not reverse the heparin until you have sorted the complication out and the perforation out and you remove your equipment. So again, in large vessel perforation, you balloon tamponade and cover the stent. It's important to know your equipment and to know to cover the stent because they are bulky, could be difficult to deliver. And nowadays they have improved dramatically, but nonetheless, they still more bulky than normal stents. So you have to know them and you have to understand how to function with them. Of course, once you put them, it's important to post dilate them because they need to come against the wall and seal the perforation well. One thing to remember here, when you put the covered stent, the bleeding might not stop immediately. So you have to give it maybe a minute or two of post dilatation. That's when will lead to good hemostasis. Knowing the covered stents is important. The older one are quite bulky, as you can see there. They're dual or double layers of metal with a sheet between. Nowadays, you have the papyrus graft or the Bentley, very thin, 5 French compatible, depending on the size, obviously, because the 4, 5, and 5 sizes are not compatible with 5 French. They have to be bigger. But they are very deliverable and very good and have proven a great improvement from the YOMED or the over and under, which were quite bulky. So you need to understand all this. So how do you deliver this covered stent? Of course, there are 2 ways. Once you tamponaded the balloon with artery, that's fine. If you have enough space in your guiding catheter, you take a second wire and you put your covered stent on it, provided the artery is prepared, and you deliver the wire toward the balloon that is blocking the artery. The minute the wire gets close to the balloon, you deflate the balloon and deliver your wire, and then you inflate the balloon again to make sure you're in control. You come to deliver the covered stent, same thing, you advance it until the tip of the guiding catheter. You deflate your tamponade balloon and bring it with the wire back, and you deliver the covered stent and inflate it, and that minimizes the time of the perforation open. Very, very quick. If you do that in bing bong, i.e. you took a second guiding catheter into the artery, you do it the same way. You keep the balloon inflated until you get your wire close to the balloon to deliver. You deflate the balloon, deliver the wire, deliver the covered stent. Make sure you remove your balloon and your original wire out. You do not want to trap them behind the covered stent. Once that's done, you post-dilate the stent, the covered stent, and everything should be fine. And this is kind of a schematic ping pong or the same guiding catheter. Excuse me. And this is where it's important to understand the compatibility. For instance, papyrus stent, up to 3 millimeters, a papyrus stent can go with a balloon in a 6 French guide. Anything above 3.5 or 4 does not go in 6 French, and you need a ping pong. Important to know so you don't rush it, you don't put yourself under pressure. What about guide wire distal perforation? About 90% of perforation with wires are hydrophilic wires. When does that happen and you recognize it? Sometimes just monitoring and just blocking the artery distally for a few minutes will allow this to settle down. If not, then you know that you have to close the artery, either microcoils or thrombin or collagen. Many things have been used, including fat. And we occasionally cover the stent across the origin of that branch may be required. We have published something called the balloon remnant again, and I see it now being used because it's a very cheap and very easy way to do it. Basically, you go back, you cut the balloon in half, you put it on the wire, take a second balloon, and you deliver this half balloon all the way to the distal part, and you leave it there and bring the other balloon out, and usually that blocks the artery. Important to know your coils. There are pushable and detachable ones. And interestingly, 64% of interventional cardiologists in a recent survey, which we published in CCI, have not used coils and don't know what they are. Important to understand them, important to know how they work, pushable, detachable, in the range of sizes. Because sometimes you need them, and if you need them in a hurry, you need to be familiar with using them. This is how we did the balloon. That's published again. That's the reference there. You take a cut balloon, you put it in, and you use the second one to deliver it all the way distally, and you leave it there, you move your balloon, and this hemostasis happens without any issue. Collateral perforation is more difficult because it leads to rapid tamponade, requires bilateral approach and closure, and balloon occlusion from everywhere. This is an example I've done before. Spent a little bit of time opening the artery, then we found an epicardial perforation. Had to go from both sides, did the open artery and the collateral to close them so they no more bleeding. Anticoagulation reversal, again, I can emphasize this, should not be the first step. Only when equipment have been removed. And you use protamine, which is up to 50 milligram, and you give it slowly because it could cause an acute reaction with the patient. Once that's done and you're happy with your perforation, you take your equipment and you could reverse the heparin. To summarize this all together, the first thing when you have a perforation identified, prolonged balloon inflation. Once you've done that, you have time to think, you have time to control, to do whatever you want. Proximal artery occlusion, perforation will need the majority of the time a covered stent. Distal perforation, probably coil or balloon remnant or fat, whatever way you learn it. And of course, you need to know your equipment, particularly the sizes of the covered stent. In a previous bypass, you have to be very careful with localized, localized perfusion, and that's important because it could be very difficult to treat percutaneously. Again, do not reverse the heparin until you finish and control the perforation. So, freely for perforation, prompt diagnosis, immediate balloon inflation, and pericardiocentesis. Subsequent management should be tailored according to the type of perforation. You have to have the perforation kit ready for use, and you have to be familiar with it. Be prepared, meticulous, and careful. Learn how to use all the management options so you can choose what works best and have a plan for your particular patient before you have the complication. The best gear is your brain. Always show your superior judgment so you don't have to use to show your superior skills, and know when to quit. Very important skill to learn and to master, because there's always another day. It could always come back. And with this, I say thank you very much, and I'm happy to take any questions.
Hadi, maybe your input on Dr. Muhannad, excellent, overview of the perforation. Are you there?
Thank you, Muhannad. Thank you, Muhannad. This was really an excellent overview, as Abdullah said.
Assalamu alaikum warahmatullah.
Let me ask you, Muhannad, particular cases, I don't know if you run across any case in your practice with left main perforation. I know it's not something common, but can you give us your feed in about it?
I would direct you. We just published a review article actually on about 3 months ago. It's open access. You could read it in CCI about left main perforation. I had over my career 2 cases where we put a covered stent and have ended up going back and re-puncturing through into the circumflex. And I said, we published this. If you search by my last name, you'll find it in CCI. It's open access. It tells you how to handle the left main perforation. They are catastrophic. So you have to act swiftly and you have to know what to do immediately. And this is where I keep going back to what I said. You need to know your equipment. You need to know how they get used and how to use them. Because when you need them, really, if you're not familiar with them, could be the difference between a very good outcome or a very poor outcome. So your left main stem is difficult to treat, but sometimes even if you sacrifice another artery, i.e. the circumflex, it's a life-saving procedure. One thing I want to say before I put any covered stent, the majority of the time I've always used a drug-eluting stent first, then I put a covered stent inside it. And my rationale is to put the drug against the wall to reduce the chances of restenosis, because over the years, covered stent have had a high percentage of restenosis and occlusion, although the newer one are much, much better. And again, hopefully our paper is under review and it will be published soon about the outcome over 10 years of covered stent. So there is an implication when there's, with the occlusion and covered stent. With the use of drug-eluting stent first, the outcome is much better. But yeah, left main stem can be catastrophic.
Khalid bin Khalid, we have a few questions. Can you read them?
Yeah, we do. So there is one question regarding the role of perfusion balloon, if any.
There is an indication. So perfusion balloon, there is a new one. It was on the market long time ago. It's gone and now it's come back. It's my understanding, we don't have it here in the UK. My understanding is about £4,000. So anyway, I think if you are the chances of not needing a covered stent and if you need a perfusion balloon for long inflation, that means you probably need to do a covered stent and it's unlikely to work. But it is available in the States. I don't know if it's available anywhere else. We don't have it around.
Actually, perfusion balloon is a very commonly available in China and Japan.
Okay,
very
good.
commonly used. So we are using from 2015, I think.
Okay. We don't have it in Europe, which is Because that sometimes can be also because if you have a prolonged balloon inflation, ischemia can become another problem. And that goes back to the most important perforation, which is left main stem. Because ischemia left main stem could be intolerable at all. You inflate the balloon left main stem, the patient will crash down. So a perfusion balloon, and I don't know how much perfusion they do, but nonetheless, they could be a lifesaver.
So Mohanad, the word never use and never reverse the coagulation is I think we should, the guidelines, maybe not to use it routinely because we have retrospective studies shows the benefit of it. But
I'm not saying never. There's never, in medicine, there's nothing is never. But I'm saying do not reverse the heparin. If you still have the perforation, if you still have your equipment in and you're using a balloon to tamponade the artery and you're still going to do anything in the artery, reversing the heparin is not the answer. There was a publication, I think about 10 years ago or more, 32% of cases where the heparin was reversed during the procedure ended up with the coronary thrombosis. And you and I know coronary thrombosis is a much, much worse complication to treat because thrombosis propagates thrombosis and becomes very difficult. So it's never to reverse it. It's only when you're in control and you know you're finished.
Until we have randomized clinical trial, we have to be careful. So
there's one more question.
Musa Akbar, yeah, go ahead, please.
Yeah, there is one more question, Dr. Mohanad, before we go to the next. What are the expansion limit of covered stents? Papillary center. How far you go in the expansion? We face some cases when you do inflation post dilatation that there are still leaking of the dye and they're giving a slow perfusion. So what you will do in these cases?
So two things here. As I said, mentioned in my talk, the perforation sometimes does not stop immediately after the covered stent. You post dilate and wait for a few minutes, up to 5 minutes, and then you find the perforation stopped. Because after you put it immediately, you could still see some leak. The second thing is to get the size correctly. So, I mean, they don't expand very well because it's understandable. If you understand there's a membrane around, if you expand it, it'll break. Probably still cause or lead to hemostasis. However, there are up to 5 millimeter stents right now, covered stent. So the range of start from 2.5 up to 5. And that's important to know. They don't expand very well. And again, if you read on the expansion chart, you'll understand how they could go.
Sure.
Musa Akbar, introduce next speaker, please. Go ahead.
Sure. Okay. Thank you very much, Dr. Mohanad, for very nice, elegant presentation, nice discussion. Now we move to the next topic. It's a glad to introduce Dr. Said Faraj, Professor of Interventional Cardiology in Zaazee University in Egypt, who will give us a talk on the equipment loss. So, Doctor, it's recorded, and then we'll have him alive, so we can address some question. So let's go to the next topic, please, the recorded one.
Good evening, everybody. It's a great honor and pleasure to for the second consecutive year to join this very prestigious meeting, very practical, very important meeting, CompEdge 2026 for Complication and Complex Cases show by the GIS. I'm really happy to contribute with just a bunch of experts, and I'd like to congratulate Professor Abdullah Shihab, Professor Musa Akbar, Professor Khalid Bentani, and all the board for this important, practical, and prestigious meeting. Actually, my presentation today is about an overview of equipment and stent loss, and I think it is also important presentation. And I think despite the modern PCI era, with a lot of tools we have, with a lot of facilitations we have, but still, due to the big volume we do now, I think the complication is still there, and some of the equipment and stent loss is still there. I'd like to start with this slide. I think it is actually written by me. The complication potentially start at the time it was not anticipated, and so no plan to prevent. It's very important to anticipate the complication from the status you have, from the angiography you have, from the clinical status you have. If you anticipate it, you will be ready and you will be able to prevent. The cause of the stent loss, which I think is one of the main equipment loss, is the stent. Actually, the coronary calcification is the main enemy for this issue. The previously stented arteries also can lead to the stent loss. Some of the procedural factors like stent deformation, forcible withdrawal, and some of the equipment-related issues like using small diameter catheter or catheter with inadequate support can increase the risk of loss. Stent advancement sometimes can lead to, with a forcible manipulation can lead to, and also I think nowadays there is no place for direct stenting. We have to prepare the artery well, because the possibility of non-optimization of the region is there, beside that there is a possibility also of stent loss. Some of the stent characteristics can sometimes help, like the ultra-thin strut stents or stents that are small may have a higher risk of dislodgement. If we are anticipating all these factors, I think we can also be careful and prevent the stent loss. If we have a stent loss and balloon partially within the stent, what is the solution? This is an algorithm, practical algorithm for how to counteract this problem. Inflate stent balloon at low pressure, like 38 atm pressure, and try to retrieve the stent into the guide catheter. If the retrieval is successful, we have all the time to check the stent and balloon integrity after the retrieval. But if failed, we have to pass an inflate 3 atm new small balloon distally and try to retrieve the stent with the balloon. If the stent balloon fails to enter into the guiding catheter, take everything out in a block together. And this is an important tip to know. And we have to know also that longer balloon can facilitate this gripping. What about if we failed? We have to know two things: the stent vessel size mismatch or acceptable stent vessel size. If we have acceptable stent vessel size, we deploy the stent in situ, step-by-step approach with incremental balloon size to deploy optimally the stent. What about if we failed to deploy the stent in situ? We can use the retrieval technique as it will be described. I will describe it to you now, the stent retrieval technique. Crush the stent to the vessel wall with another stent. But the last option in the left main cases, we can take care of that. Try to advance the lost stent with a slight inflated balloon to appropriate site. We can use the balloon as a pushing device to the distal vessel. And this also will be the techniques we use if the stent vessel sizing is mismatching. What about the total loss? Try to pass a small balloon again with single marker to recross the lost stent, inflate the balloon at 3 atm pressure, and retrieve the stent as described in a partial stent loss, as we mentioned. If retrieval is successful, we have to check the integrity, as we mentioned. What about if we failed? We have also to recheck the stent vessel sizing if it is acceptable or there is a stent vessel mismatch. If it failed, the site of the stent dislodgement is very important. If it is proximal, use the snaring technique to retrieve the lost stent. If it is proximal or middle, use the multi-wire technique to retrieve the lost stent. Stent alignment upon the retrieval is very essential. I will show you now how we can do both techniques. If failed, crush the stent to the vessel wall with another stent, and as I mentioned before, last option in the case of left main. This is one of the stent retrieval technique. If the dislodged stent on the wire, advance a new low profile balloon as you see, cross the dislodged stent, inflate the balloon distal to the stent at 3 atmospheric pressure, withdraw the stent and balloon through the guiding catheter, and sometimes we need to do that in block as one, all the tools all together. This is the snare loop technique for stent retrieval. Lost stent on a wire, we can extend loop snare out of its catheter, as you see here in P. lasso loop snare around the stent and pull the stent into the snare catheter and withdraw. This is another way to, we have to know that this is a micro snare to enable it to catch the stent and get it out from the crown. And here is another way to dislodge the stent, advance the second wire through or around the struts of the stent, and do a twist ends of both wires together, distal to the stent, and as you look at here in D, twisted distal end strap stent, remove the wires with the stent. Sometimes also this technique, multi-wire technique, can succeed to retrieve the stent. What about if we have a balloon shaft? We have to inspect the shaft. This is by fluoroscopy. Balloon shaft within the guiding catheter, we can do what's called balloon trapping technique, using a 2 millimeter balloon for 6 French and 2.5 balloon for 7 French. And what about of the balloon shaft inside the coronary but outside in the guiding catheter? In the aorta, we can do snaring or unfortunately surgery if we fail to snare. Inside the coronary, we can use the snare. We can use the fixed procedure with a stent if the balloon segment is confined to the coronary artery, but this should be with caution with regard to the left main stem. Also, the surgery is option, but conservative approach is not recommended at all for those with balloon shaft fracture and loss. The wire, the guide wire also is one of the last tools, and also, as we mentioned before, the unprepared vessel, the calcification, the excessive bending, the over-rotation, the guide wire jailing also is very important cause for guide wire entrapment, wire loop formation. Also using nowadays we're using a lot atherectomy over a kinked wire can also bend or kink the wire and increase the risk of entrapment. Also, now we do a lot of complex lesion with the possibility of stacking of the wire, entrapment of the wire, and cut of the wire. Part of the jailed wire behind the stent strut confined to the coronary artery or free wire distal to the stent. This is the situation. If yes, we have to individualize the anatomy assessment. Fixed with additional stent can be an option, and sometimes a conservative approach, especially if small territories or small vessels, can be also an approach for the wire loss. But if no, identify the fracture site of the wire. Stent enhancement technique can be very helpful, and also using imaging technique like OCT or IVUS to identify the fracture site, to plan for that. Free wire in the left main stem. If this is not the situation, consideration of anatomical facts and doing a conservative approach. And this is very important to consider the anatomical facts like the risk of side branch occlusion. If yes, the free wire in the left main, we can attempt the wire removal using micro snare, and if failed, using the multi-wire. Sometimes we can fix it with additional stent, or if we failed, we can use the surgery or conservative if there is no risk, anatomical risk, if there is no risk for side branches or big arteries. What are the learning points from the situation we faced if we need to anticipate and to prevent against the equipment loss? Avoid direct stenting, especially in the tortuous and calcified vessel. This is very important. Meticulous vessel preparation, often using atherectomy in calcified lesion and intracoronary imaging to confirm adequate lesion expansion before attempting stent delivery. This is how we anticipate, how we deal to prevent. Stent from distal to proximal. Sometimes, however, the need for distal stenting does not arise until after proximal stenting is deployed. For example, in case of distal edge dissection, sometimes it is a situation and sometimes it leads to stent loss. Use a guide catheter extension for delivering stent in a tortuous calcified vessel. Do not advance forcibly in tortuous vessel, especially if it is calcified, because the incidence of losing the stent is very, very high. avoid forcible advancement attempts, as we said, and also drilling of the guide wire in a calcified lesion. A lot of drilling ends in a guide wire tip jailing and cut and loss. Retrograde wire strong manipulation, especially in the era of the CTO intervention, knuckling increase the risk of wire decoiling, especially in a guide family. Usually, the residual part of the wire in the coronary, especially if it is distalized artery, does not cause any problem. But we have to try to break the guide wire as close as possible to the tip to minimize the area lost in the very distal artery. Sometimes it left with no problem. Actually, I have a very interesting case. I will show you the case here in a few minutes. It is a male patient, 56 years old, diabetic, hypertensive, current heavy smoker, presented to our hospital after midnight with a STEMI inferior wall MI and complete heart block about 2 hours from symptoms onset. Blood pressure was 90/60 with a heart rate 35 beats per minute. Pushed to the CAS lab for primary PCI after insertion of a temporary pacemaker. I will show you the case now. As you can anticipate here, this is a calcified total occlusion of the distal right coronary artery, as you see. And of course, we can anticipate here that the calcification will be the cause of the problem. Next. Next. Actually, this is after some preparation of the artery. Sorry for the image because it is done a long time ago. After preparation with small balloons, we can appreciate here that the artery is now appearing down, but unfortunately, I think it is not well prepared. Next. And this is during the stent positioning. I think the operator at that time facing problem in stent positioning because the artery is not well prepared, and also there is a kink, as you appreciate, in the mid-to-distal artery, as you see. Next. We can appreciate here the stent dislodgement, and unfortunately, the stent and the wire and all the equipment are lost from the engagement side. So now the stent is circulating in the circulation. We don't know where is the stent. And after a lot of search, continue. Next. After a lot of search, we can find the stent at that time. It is in a place in the aorta, as you see here. We use a handmade snare. We're using the PCI wire in a trial of catching and retrieving it, as you see. But actually, we failed after a lot of manipulations in a lot of projections. Next. At that time, decided to take an injection to see if the stent is positioned in a dangerous place to block any of the arteries, like the renal arteries or something like that. But actually, the injection here give us the idea that everything is clear. At that time, decided to do a CT angio for the aorta. And there is a big surprise that the stent is in the safest place in the world. It is in an ulcerative lesion in the aorta, like a pocket. It was dropped in the pocket in the aorta, ulcerative lesion, and it is in the very safe place. And the vascular next, please. And the vascular surgeon at that time, the decision is to leave it in place because it is trapped in an ulcerative lesion in the aorta, and it will be no problem for this stent. It is very strange that sometimes But we have to search. We have to know where the stent. This is a very important message. We have to know where the lost stent. As in our situation, if it is in a safe place, okay, we can leave it after MDT with the vascular session. Next. Finally, I'd like to thank you all. And one of the important messages that we have to leave when we are handling the complications, that we have to be calm and manage the loss of property reasonably. Thank you for your attention.
Standing. Thank you very much, Doctor. My first comment on this, with this advancement what we have in technology, PCI, I think Dr. Misbahul mentioning, of course, stay away from what tertiary hospitals, still people do this. But imagine we are in the right place, we have everything right. Should we blame any more the equipment, or should we blame the operators, as you mentioned at the beginning, the preparation? I mean, give us your experience in this. Why we're still losing equipment? Is it because is an inherent complication, or is because of still the operator experience and the part of
I think it's a very important question. I think we can blame both. Sometimes we can blame the equipments, and sometimes also we can blame the operator. As in my case, I presented, if you notice that this case was done at the midnight, all are exhausted, and sometimes we do not do the job well because very heavy day, and it is a midnight, so no well-prepared artery, so we can lose the equipment. And as I mentioned, sometimes if we are facing a calcified artery, and we do all we have to do for debulking the calcium, and then we use, for example, an ultra thin strut for stents, and this stents is very amenable to be lost, so it can be the cause from the stent itself, because it is ultra thin strut stents, and sometimes we can lose it if we still have some calcium in the lesion. We cannot appreciate it. So sometimes it can be both. And as I said, despite of the modern era of PCI, a lot of tools we have for debulking, for assisting the delivery of the stent, we still have a big volume now. We are doing a big volume of complex PCI. So of course, we still have a complication because of the increasing volume of the PCI we do now.
I want to add one more point. Like now is 2026. When we start our PCI journey in 2012, I saw last 10 years journey. Day by day, we are talking about the high quality instrument, but honestly speaking, at least 50 to 60% case we can manage with this small balloon and the guide wire winding technology and the small balloon. So first of all, for all the complication, if we think the two technique, the small balloon and the guide wire winding technology, if not succeed, then we can think about the high quality instrument. So I think humble request to all the cardiologists, any kind of complication is acceptable, but we can avoid the complication in the future with the good training and the safe PCI journey. So that's all from my side. Thank you.
Last question there is here. Question is that last, and then we'll move to the next speaker. Is there any, what should be the ideal inflation, Dr. Firdaus, ideal inflation pressure of a small balloon retrieval option? What is the ideal? It's a low inflation pressure. What's the ideal inflation pressure?
It's 3 ATM below inflation. It is 3 ATM. 3 ATM, I think it is suitable. 3 ATM.
Yeah.
Very perfect, because the small balloon all time at least 20 to 30% case with the stent loss, so we just put and the distal side, then we can take it out. I think most of the case we succeeded with the small balloon. Thank you, sir.
Sure. Thank you very much. Now we know. Thank you very much, Dr. Said Faraj, for
that
elegant presentation. Now we move to the next topic. It's glad to introduce Dr. Hamid Al-Ghamdi, consultant interventional cardiologist from Saudi German Hospital in Khobar in Saudi Arabia, who will give us a talk on no reflow phenomena. Dr. Hamid.
Assalamu alaikum. Good evening, everyone. and thank you to GIS for their kind invitation and their unwavering support for continuing medical education. The title is regarding node flow in acute coronary syndrome, from prevention to management. So the outline of the talk will focus on a few points with regard to this phenomenon, including the incidence. I will share with you clinical cases that I hope will illustrate the difficulty in challenging managing those patients. And we'll touch on some background science, including pathogenesis predictors, clinical consequences, and hopefully we'll end up with some preventive measures and management of node reflow. By way of introduction, this phenomenon is not new, has been described in the mid-90s of mid-60s rather, of last century by Krog, and it has become more significant and more recognizable in the 80s with the ushering of the era of angioplasty as the management of acute coronary syndrome. TIMI flow grade 3 has been gold standard for reperfusion success, and node reflow has been defined as TIMI 3, TIMI flow less than 3, and as myocardial flushing grade less than 3, or TIMI 3 and myocardial flushing grade less than 2. So that's the widely agreed upon definition. The incidence is rather variable. And do believe that when you look at the literature that the incidence is underreported. It's been estimated to range between 5% all the way up to 60%, depending on the way they define it and they look at it. TIMI, for example, TIMI 0 to 2 is seen in 5 to 10% of primary PCI patients, and myocardial flushing grade 0 to 1 is seen in up to 30% of patients with TIMI 3 flow. And it's particularly more common in degenerated vein grafts and following rotational atherectomy. Allow me to share some cases with you. Start with the first case. This is somebody who presented with infraposterior MI. You can see that his right is very tight and chronically occluded. Sorry. The surface totally occluded, and after you can see after we open, and this is a culprit vessel, after we pass the wire, you can see a long laminar clot occluding the vessel. We did multiple inflation, and you can see at the end, after multiple inflation of both branches of the OM, the flow was extremely poor. We can probably consider that as TIMI 1.5 flow. It's not even TIMI 2 flow. So we decided to leave the patient for a few days to maximize his antiplatelet, anticoagulation therapy, and to bring him to the cath lab. So this is when we end. Just to remind, this is the patient initial angiogram, totally occluded, OM is the culprit, and this is after we took the patient, sorry. After we did PCI, after deferring the patient for 48 hours, it's not the best result, but this is much better than intervening early on when the patient had very poor flow. Now, this patient, we ended up with acceptable outcome considering the case. But when we compare to the second case, which belonged to a patient who presented with high risk acute coronary syndrome, patient presented with anterolateral STEMI and early cardiogenic shock. You can see the culprit is mid-LED, totally occluded. Okay, and this patient also had subtotal occlusion of his RCA, and because of his hemodynamic instability, decided to do his RCA quickly. So we did the RCA, then we switched to the culprit, which is the LED. So we did the usual, we opened the balloon, then after that, multiple opening, still no flow. We used atherectomy, you can see on this right-hand side of the screen, and we got very minimal clot. Again, no flow, integrated flow. We push the wire all the way down. LED, we did the injection, you can see it flows back. And we delivered multiple medications here with the IVUS to understand what happened. I wouldn't bother you with the IVUS, but anyways, during that time, patient became unstable and he had VT, cardiac arrest. We had to rush and try to open it. So we started ballooning. Then after that, we put a long stent. But you can see after stenting the artery, again, unfortunately, no reflow. Again, we advanced the aspiration catheter distally. You can see multiple clots from the mid-segment all the way distally. We started delivering all the available remedies for such case, but unfortunately, patient stayed in refractory VTVF, and unfortunately, despite 1 hour of CPR, patient expired. So forward and talk about the pathogenesis of this problem. It's well known that it's multifactorial phenomenon. There are 5 different mechanisms described, including individual susceptibility to microvascular dysfunction, pre-existing microvascular dysfunction causing impaired clinical flow, distal microthromboembolization, another mechanism, and along with that, ischemic injury as well as reperfusion injury. And it's well known that these 5 different mechanisms interrelated in a complex manner, leading to no reflow. So this diagram shows clearly the way these different mechanisms interplay. So we have somebody with individual susceptibility, multiple risk factors for developing no reflow. Along with that, we have the ischemic damage, followed by distal embolization leading to reperfusion injury, and that will cause no reflow. And if the patient are lucky, it might be transient, and as you saw in the second case, was unfortunately sustained with very dire consequences. What are the predictors of no reflow? Multiple predictors have been actually described in the literature. We have duration and extent of ischemia, clinical risk factors of that, including hypertension, smoking, dyslipidemia, diabetes, as well as degree of inflammation. Tense inflammation tends to increase the risk for no reflow. This is another table to show you the unfavorable. Can you just focus on the unfavorable predictors of no reflow or slow flow, including the age, number of Q waves, lesion length, thrombus grade, syntax score, baseline TIM score, and the use of intra-aortic balloon pump, as well as prolonged reperfusion time and low blood pressure or cardiogenic shock at the time of presentation. All these will increase the risk of no reflow. It's also, they describe that favorable situation for that potentially sort of prevent or minimize the risk of no reflow, including prior use of statins and history of previous, and hypertension. Probably they meant by that high blood pressure no presentation. It might actually help prevent or minimize the risk of no reflow. The way we diagnose no reflow, we can just use the standard of practice, use ST segment resolution by AKG. Coronary angiography is the standard of practice using TIMI 3, widely used, as well as myocardial blushing rate for more specific characterization of reflow. Also, they describe myocardial contrast echocardiography, or the use of cardiac magnetic resonance, which is probably not that common in clinical practice. Moving on to the clinical consequences of no reflow, you can see that those patients who had no reflow, now the black column of those patients who developed no reflow, you can see that across all different outcomes in hospital mortality, reinfarction, cardiogenic shock, and heart failure, patients who had no reflow had actually much worse outcome compared to those who did not develop no reflow. When you look at the outcome as well, based on the presentation, whether those patients presented with STEMI or non-STEMI, also the same. Mortality, myocardial infarction, cardiogenic shock, or heart failure or stroke, it's much worse in those patients who developed no reflow compared to those who did not develop no reflow. And you can see, for example, the mortality is multiple folds compared to those patients who did not develop no reflow. When you look at the outcome using different diagnostic methods, so when you look at the prognosis no reflow using angiography, for example, 23 flow. So those patients who had no reflow, normal brisk flow at the end of the procedure, okay, compared to those who had no reflow, you can see that the cumulative mortality is significantly lower in those patients who had no reflow, up to 3-4 months from the initial presentation. And when you use as a segment recovery and myocardial blush, you can compare the green bars, which represent those who had excellent outcome, more than 70% as the segment resolution, and blush grade 2 to 3. Their mortality at 1 year is 1.2%, compared to those patients who had less than 70% as the segment resolution and blush grade 0 or 1. Those patients had very poor outcome, which is almost tenfold those of good outcome. So those patients had around 10% mortality. So you can compare almost 1% compared to 10%. So this is a very drastic difference. Also, when you use different modality, including myocardial contrast or magnetic resonance, it all basically show you the same result. Those patients who had microvascular dysfunction due to no reflow had actually much worse outcome compared to those patients who did not have myocardial or microvascular dysfunction. How to manage those? Unfortunately, there's no different. We usually tend to resort to a combination of different strategy in the cath lab. Modification of PCI is an important consideration in these cases. And there will be no available therapies, including thrombus aspiration, glycoprotein, adenosine, cardinal nitroprusside, just to name a few. Modification of PCI strategy. We mean the use of thrombectomy when you see large clot burden, deferred stenting, direct stenting, avoidance of post-dilatation, distal coronary administration pharmacological agent using microcatheter is also one of the important studies advice in these cases. I'll just fast forward to the deferred stenting, and I'll just go through some of the studies that showed sort of conflicting outcome and results. The first STEMI included 101 patient, and no reflow occurs in 10% of patient primary PCI. And the conclusion of the study that in high-risk STEMI patient, deferred stenting and primary PCI reduced no reflow and increased myocardial salvage. So this, one of the early studies, showed actually a good outcome. Now another study, including it's called MIMI study, also compared immediate with delayed stenting using minimalist immediate mechanical intervention approach in acute STEMI, and the outcome of those patients basically showed no benefit at all when they compared both approaches, immediate stenting versus delayed stenting. So this study is considered basically negative study, showed no difference for deferred strategy. You can see that the number of that study is not big, but again, it shows us only marginal, sort of a trending towards the delayed stenting. So probably the small number of the study is the reason that did not show benefit in deferred strategy. Dynamic 3, the first study, also showed no benefit. You can see that those curves, overlap, and it showed no benefit, conventional group versus deferred therapy. When they also looked at those patients using a more accurate assessment from the CMR sub-study from that, Dynamic, the first study, the Dynamic 3, it showed again no benefit, comparing conventional versus deferred strategy. What should be the ideal deferral time? We don't know, and that's one of the issues when you look at all these studies together. Multiple studies actually use different times, starting from less than 24 hours all the way to 7 days with variables. So unfortunately, we don't know exactly what's the best strategy when we defer those patients. So it comes down to the primary operator discretion. When they looked at all studies combined together, okay, collaborative meta-analysis, comparing, combining the major studies, including NAMI3, the first study, innovation, and MIMI study, the result showed a trend towards benefit of immediate intervention rather than actually deferred strategy. Intra-procedural management of fluid flow, as I said before, no definitive therapy. Combination strategy is very common practice. It's an important to consider modification of PCI and to use injectable therapies. We'll just review a few ones, including adenosine, which is very common agent that we use in the cath lab. Okay, both Amistad trial, first one and the second one. The first one showed relative reduction in farm size, but the second one showed no benefit. So therefore, it's assumed that adenosine administration was associated with better clinical outcome patients who achieved early reperfusion. So those patients who came late, probably they're not going to benefit that much from adenosine therapy. So again, you can see the trend that the data is conflicting. Nitroprusside also showed no clear benefit. It's one of the agents that we use, okay, but no strong data to support a clear benefit. And you can see this reopen AMI comparing adenosine and nitroprusside, and you can see there is a more slight trend towards benefit of adenosine compared to nitroprusside. I'll just fast forward for the sake of time, but this is again from Reopen MI study comparing the outcome. There is no huge difference between the two. Calcium channel blocker, we don't use it around here, but again, it has been described that it might have a benefit, but there is no strong data to support its use. And one of the big limitations of calcium channel blocker is the hypotensive response to it. I will close with this study, which is a cohort trial, which looked at the use and the safety of using epinephrine and no-reflow versus adenosine. And this study showed that those patients, especially those with borderline blood pressure, they actually might benefit from epinephrine use intracoronary in those patients who develop no-reflow. So it should be considered in those patients, especially patients with borderline blood pressure or hypotension. Use of epinephrine has been shown to be safe and probably helpful in no-reflow. So the summary: no-reflow is common in STEMI. No-reflow carries very poor prognosis, as we have seen in clinical case presentation and the data presented. Currently, there is no consensus on how to best treat or manage no-reflow. Defer PCI, despite conflicting data, seems to have a very favorable outcome in high-risk patients. We should select them carefully. Combination therapy is a common practice depending on patients' hemodynamics. And unfortunately, no-reflow may prove resistant to pharmacological therapy in 5 to 10 patients, 5 to 10% of patients, and unfortunately with very unfortunate and catastrophic consequences. Thank you so much.
Hamid, beautiful presentation. Let me bring Muhannad and Hadi here. You know, people talk about no flow and no reflow. Maybe you give us an opinion about that, because people mixing that, you know, because they say TIMI3, but still no reflow, but there's, you know, they're not looking. So I'd like just take us to the basics, then give us your experience how to manage the no reflow, both Muhannad and Hadi.
Go ahead, Muhannad, if you like.
Really well mixed up. No flow, I suppose if you do a rotablation and you end up having the RT was flowing before and then there's no flow, that's no flow. The no reflow, I think, is more for acute MI. because the artery is occluded, there's no flow, and then you open it up and still it is no reflow. It's a little bit kind of academic, if you like. So to my mind, I don't think there is any direct or any good treatment up till now. Certainly in my experience, nitrate, intracoronary, important. This is the most important message, I think. If you're going to deliver any medication, deliver it into the distal bed. So injecting it through the guide catheter does not work. Take an aspiration catheter or a microcatheter, usually aspiration catheter, much better, deliver it distally. And sometimes if you can't see, you could use some also contrast to see the distal bed. But deliver it in the distal bed. For me, nitrate and sometimes adrenaline are the most kind of most helpful medication. But time is of essence. You give them some time and they recover. And again, if there's no good flow, do not put a stent in. End of story. You could always come back.
Well, I think what you said, Mohanad, is important because no flow, no reflow. I mean, it's just a matter of semantics, actually, Abdullah. The thing about it, the studies which was shown, you see that the percentage is a bit high in some of the studies. It's because, let me alert you, if you have somebody with an open artery at the site which was occluded and you have a TIMI2 flow or TIMI1 flow, that's considered no reflow. Remember that. I mean, we don't look at it this way sometimes, but that's why the numbers might be higher than what we report sometimes. And the other thing, as Mohanad mentioned, I don't use, Mohanad, a lot of nitroglycerin for the distal bed because I'm not sure how good it works. But as you mentioned, it's so important to deliver it distally with a microcatheter or what have you, because if you just deliver it to the epicardial vessel, it just simply doesn't work. And I've been very lucky, especially if the patient is hypotensive a bit, epinephrine works magically. If you use it cautiously, like 50 mics increment until you reach like 500 mics. The thing which I noticed one slide, and I have to do a warning about it. Yes, in thrombus containing lesions in acute coronary syndrome, especially STEMI, don't do post dilatation. Yes, we don't, right? But what is more important than that, it is more important to use the right stent size to begin with. And that's always a challenge in STEMIs because of the vasoconstriction in the vessel. So make sure the size of the stent is very good before you decide on no post dilatation. Thank you.
Al-Ghamdi, you always give us update things in this which is we still don't know, as everyone says. We don't know. In your practice, when do you use intracoronary adrenaline?
Okay, so as I said, there is no single intervention that will prove effective in these cases. It's a trial and error even in the cath lab. But I think, and I do believe that the best strategy would be less is more in these cases. But it's important actually to establish some form of antegrade flow. Okay, then you stop, allow time, patient needs time, as Dr. Mohanad said, time for great essence in these cases. And that's probably the outcome is variable from, study to study when it comes to differing stent. Okay, but I think the bottom line is give the patient time, because interfering in these cases, the patient is unstable. It's a sign of instability of the flow, by the way. Okay, so you stop, give him time to recover. The use of, nitroglycerin, I stopped using it. Why? Because especially in those patients who are hypotensive, I don't use it. I use adenosine with caution in soft hemodynamics, okay? And I started actually using more and more for the last probably couple of years. Adrenaline, okay, epinephrine. If the patient is borderline hypotensive or in cardiogenic shock, I use it actually more often. And as Mohanad said, I push my aspiration catheter because I use it a lot distally and deliver these medications. And give him time and wait to see the outcome early on. If the flow is normalized, I might just go ahead and stent. If not, I wait. I bring him back in 2-3 days to reassess and do the stenting.
Musa Akbar, give us a latest, literature review last time in Egypt. For us to, tomorrow I have a case. What's your most important factor that this patient going to have a no reflow? From what you've read and what you've experienced?
No reflow, there are predictors. If you have...
Give me the most important one.
there are many factors. So the heavy burden thrombus and acute coronary syndrome is a factor for no reflow, and that's the most important factors if you want in summary. The other thing, there is a very nice recent review article in May about no reflow neurointervention last May. So that's a very nice algorithm of how you approach it, whether the patient's stable or decompensated with the cardiogenic shock, how you do it for no reflow.
Yeah. Okay. Yeah. Maybe Khalid Ben Thani, you introduce next speaker, and maybe Faisal will give his comment before he starts.
One last comment, Abdullah, if I may. Total ischemic time is one of the major predictor of no reflow.
Khalid.
Okay. Thanks, Dr. Hamid. Even though there was a comment regarding the coronary ectasia as one of the predictors also for the no reflow. Our next speaker is Dr. Haidar Arjuman. He is the Group Chief Medical Officer for the American Hospital in Dubai, the United Arab Emirates, and he's going to talk about cardiogenic shock as a complication of PCI.
Good evening. Our tonight's presentation titled Hemodynamic Collapse and Cardiogenic Shock, a Case-Based Management. I'm Dr. Haidar Arjuman, Group Chief Medical Officer at American Hospital in Dubai. It's a pleasure to join you virtually. This is an outline of my presentation, which is essentially three parts. The first is a case presentation and staging of cardiogenic shock. The second part relates to management of patients with cardiogenic shock, particularly with regard to revascularization and mechanical circulatory support, or MCS. And the third, brief discussion about future direction in cardiogenic shock, specifically different types of MCS coming down the pipeline, and how do we monitor clinical progress of patients with cardiogenic shock. So with regard to the early diagnosis and management, these are some recent publications, particularly the 2025 concise review by American College of Cardiology, and a very nice review in NAJM in January 2026, which are very useful for references. Our case involves a 45-year-old gentleman who had presented to outside hospital with chest pain, which had been going on intermittently for 18 to 24 hours. As you can see, the patient has multiple ischemic risk factors. Initial evaluation in the emergency room showed borderline blood pressure of 95/53, elevated heart rate and respiratory rate with reasonable oxygen saturation. ECG showed sinus rhythm with left bundle branch block. It was not known whether this was new or old. Laboratory data showed significant abnormalities, including elevated troponin, elevated creatinine, elevated ALT, and a lactic acid, which was high and rising. Initial echo showed an ejection fraction of 35% with anteroapical hypokinesis. This patient actually had coronary angiogram at outlying hospital and was referred to us for consideration of CABG surgery. I'll get back to the patient in a second, but because of the hemodynamic that you saw, when the patient was sent to us, we're concerned about cardiogenic shock. And of course, this is from ACC/HA guideline. That's most important thing is suspecting cardiogenic shock, hence the mnemonic suspect CS, which abbreviation for symptoms and sign, urine output, sustained hypotension, perfusion, ECG/echocardiogram, congestion, and triaging the patient, followed by SCAI classification. This is SCA classification of cardiogenic shock from A to E, A being at risk, E being extremis, and most of the shock we might see is C. This patient, based on initial evaluation, we thought is B going into C, which happens quite often, and that's why we need to suspect it very early and address it very early. Now back to the case, these are the initial angiogram of the patient. You see the right coronary artery, which has mild distal disease, also right to left collateral, filling the distal left circumflex. And on the right, you see the left coronary system, significant subtotal occlusive disease in both LAD and diagonal, and an occluded circ, hence the right to left collateral from distal RCA. Now, patient came to us with the impression of needing open heart surgery, and in fact, he did have multivessel disease, but mostly involving LAD and diagonal with a chronic total occlusion of left circumflex. Based on patient's clinical condition and shared decision-making process, especially as his condition was getting worse and the patient was declining CABG surgery, shock team discussion, multidisciplinary team, we decided on MCS and in particular Impella-supported PCI in the setting of evolving cardiogenic shock. You see the femoral axis, you see blood flow, how it's sluggish, indicating underlying cardiogenic shock. You see the Impella CP going in for supporting in the setting of acute intervention. These are pictures of the left coronary system. You see the cine video of left circumflex occlusion and significant disease in both LAD as well as major diagonal. So essentially representing a complex LAD bifurcation diagonal disease. Because the left circumflex was completely, totally occluded chronically with left to right collaterals, we concentrated on LAD, and you see both LAD and diagonal wired. Initial balloon angioplasty of both LAD and diagonal, stenting of mid-LAD, stenting of diagonal, bifurcation mini crush technique, and you see kissing angioplasty of both. We actually did pod proximal optimization technique followed by kissing balloon inflation. And this is the result. We got very good result. Now, because patient had the left bundle branch block, we opted to do the hemodynamic but do not leave the Swan right heart catheter in place because of risk of potential complete heart block. But the hemodynamic did suggest that patient had reduced cardiac output, and in fact, consistent with his clinical and hemodynamic parameters, he was in stage C cardiogenic shock. This is update on the patient, cardiac cath with shock team MDT, complex PCI of LAD diagonal bifurcation with Impella CP, had Impella for about 40 hours with improving lactate. Patient was discharged home on day 5, and 1 month later, his ejection fraction was 55-60%, which at baseline had been 35%. In fact, I saw the patient not long ago and was doing very well. The second part of my presentation relates to management of patient with cardiogenic shock, particularly mechanical circulatory support and revascularization, and brief review of clinical trial data. Now, this is result from the shock trial. This now goes back over 25 years. We know the shock trial randomized patient to early revascularization medical therapy. This is the trial which paved the way for revascularization that we do in patients with acute MI and cardiogenic shock. This is the long-term data. We know at 1 month this was not significant, but at 6 months and 6 years this was significant. So the revascularization is the most important core principle in patient with cardiogenic shock based on that shock trial. Now, of course, as it relates to mechanical circulatory support, we always have to discuss what type of device is available. and what is the capability of each center in utilization of these MCS devices. These are some of the clinical trials which unfortunately did not pan out with regard to both balloon pump and ECMO. For the sake of time, I will not go into details. Needless to say that the patients who were randomized, according to how randomized, neither balloon pump nor ECMO provided any benefit in this patient's population. Now, of course, you say why this did not provide any benefit. The reasons are variable. Maybe wrong patients were included. Maybe a patient already had end organ damage, including multi-organ failure. Maybe because the cardiogenic shock heterogeneous population. So the reason could be multiple, but it's important to view a negative trial in the context of the patients who are enrolled in the trial rather than just whether this device works or doesn't work. One thing is critical in places that have shock team and shock centers in place. So shock team is an important element of providing patient optimal treatment in the setting of cardiogenic shock. And the shock team members obviously come from cardiology, interventional cardiology, critical care, cardiac surgery, cardiac anesthesia, and is critical for every center's aiming to provide high quality care to this patient population. The only trial that has so far shown improvement in the outcome of patients with cardiogenic shock using mechanical circulatory support is the Danger Shock trial, randomized patient with cardiogenic shock with elevated lactate and those who required vasoactive support, but excluded patients who were comatose, RV failure, mechanical complication. And the main MCS was Impella CP. Some patients did get VA ECMO, but the main thing is the culprit PCI strategy was the main. So multi-vessel PCI for the most part was avoided. There were some patients who did have non-culprit PCI. And you see this is the primary endpoint. At 6 months, 58.5% of patients in non-device group had adverse outcome compared to 45.8%. This is an absolute 13% reduction. Unfortunately, this significant improvement came with the cost of higher vascular complication as well as higher bleeding and renal replacement therapy. So this is what I labeled dangers of danger shock trial. So ability to do optimal vascular access and preventing vascular access complication, very important. Equally important is smaller devices, which I will discuss briefly. This is the long-term result of the danger shock trial, and you see going up to long-term, it still shows significant benefit of 16% absolute mortality reduction up to 10 years. Obviously, this is according to KM analysis, but needless to say that these patients continue to benefit, similar to the patients who had revascularization. Long-term, they continue to have benefit from revascularization. The third part, future direction in cardiogenic shock, particularly mechanical circulatory support. The main important thing to know about the new MCS devices coming down the pipe is the aim is to provide the same augmentation in the cardiac output with reduction in the size of the device. Because we just shared that from the mechanical circulatory support Impella, the danger shock trial, that it showed significant improvement in outcome, but higher risk of complication, quite a bit of it related to large size device. So these are example of a smaller size going in. The profile of these devices is small, and from 8 to 9 to 10 French, but these are expandable devices. So when they are inside the body and in the left ventricle, they expand to 20, 22, 24 French. And as a result, the cardiac output that they provide is significant. And this is the future of cardiogenic shock support because of the smaller size device and hopefully lower risk of complication. This is a head-to-head comparison, not really in a randomized trial. This is my attempt to show the device size compared to Impella CP, 14 French, while these devices are at 9 and 10 French, but the cardiac output is as good or better. Number of clinical trial ongoing to show the benefit. And finally, how do we monitor clinical progress? So obviously, yes, door to balloon time is important. Door to support, placing the mechanical circulatory support is very important, but also how do we monitor these patients? In addition to hemodynamic and clinical, the most recent paper from Society of Cardiovascular Angiography Intervention relates to DLC or SCAI DLC, which is door to lactate clearance, which means we need to measure lactate on presentation and then every 6 hours measure lactate, and using this formula, which is initial lactate minus subsequent lactate divided by initial lactate times 100, is assessing what is the lactate clearance. If the patient lactate clearance is improving and the lactate is lowering, then it means we're going the right direction. But obviously, if the lactate is increasing, then we need to rethink the process and we may need a stronger mechanical circulatory support. Finally, and as an overview, where we going in 2026, 2027, up to 2030, patient selection is very important. Type of device is MCS device is crucial. Which patient should we include? What revascularization strategy? And most importantly, size of mechanical circulatory support microaxial flow pump, 8 to 10 French, before PCI, and monitoring clinical progress with DLC or door to lactate clearance. This is the latest presentation from Jack in April 2026, that we need to continue to monitor these patients in addition to mechanical circulatory support and revascularization. We need to optimize their guideline-directed medical therapy, see them for follow-up in a multidisciplinary fashion to make sure that they continue to do well.
Excellent. Thank you very much, Haidar. You are the father of this cardiac shock in our region. So basically, we are moving to the precision medicine. That's what we need nowadays. The AI finding the right patient, right device, right time. I mean, this is very difficult. I mean, how can we do that with the limited number of the cardiac shock we're receiving? And I don't know. I mean, I want everyone's input here with those who have experience in this field. Maybe start with Muhannad.
Early to support before any intervention or any coronary intervention to make sure that you have given the left ventricle and the patient enough support, and then you could go and do whatever you need to do. So I think Impella still has a very important role, but getting the timing right is the most important part.
Then Thani, we have questions on the.
Yeah, you see, Dr. Abdullah, I mean, it's a great presentation from Dr. Haidar. And to our panel here, Dr. Musbah and also Dr. Hadi, the question about the usage of the right heart catheterization in cardiogenic shock and its usage and in its daily practice. I don't know about your how to proceed usually in cardiogenic shock in such situation. Do you use it regularly? Is the case?
Diagnosis secure. If you're in a bit, if that's a different story. You could measure the vascular resistance. You could measure the right. But if it's cardiogenic shock, I'm not sure how that's going to change. I'm more than happy to hear other people.
Just challenge that view, Haidar. See what you think.
If I might jump in.
Yes.
So I think the similar to the timing of mechanical circulatory support, same timing applies for pulmonary artery catheter. I totally agree with the timing of MCS. It definitely needs to be before PCI, because once the spiral down starts, it will be too late. With regard to pulmonary artery catheter, while we don't have any randomized data, but this SCI staging has been applied to several databases, including from Germany, from Mayo Clinic, from a number of things. and the PA catheter has been an independent predictor of improved outcome. The timing is important. I agree that we don't need it at the beginning, but once we do the MCS, once we do the PCI, we definitely require a PA catheter to assess our cardiac output, cardiac power output, and because the CPO, the cardiac power output, is an independent predictor of outcome in cardiogenic shock, and depending on whether our CPO is or more or less than 0.6, and also in the setting of right heart failure and right ventricular dysfunction, we would have to look at the pulmonary artery pulsatility index, PAPI. So we definitely, once we're done with the PCI, every cardiogenic shock patient should get PA catheter. In fact, even patients that for me, a stage B, so if I'm doing a PCI on a high risk anterior MI and the patient is not in a stage C cardiogenic shock, I do PA catheter on those because that may identify patients that clinically are still good, but they have reduced CPO. So, and there is a randomized trial ongoing to prove this in a randomized manner.
Can I have, since we have Faisal Goofy here, Faisal, you've done a lot of things in this field. What do we need nowadays? More devices, more system. What do we need actually to improve this?
Complication related to the MCS device, vascular complication, sepsis, respiratory distress. So I do agree with, if you are putting an MCS device, a SWAN catheter has to be in place because the communication among you and your team is only dependent on the numbers of the hemodynamics. Lactate is important in our routine, in our multiple devices we use in our center have its own protocol, but lactate is an important aspect. And if you look at the SCAI classification and other classification, it's only dependent on the SWAN number. So if we are to consider using an MCS device, I do believe that the patient has to have a SWAN in order to ease the communication among the colleague in the shock team. And I'm a bit reluctant to say that what made the difference so far in the care of a cardiogenic patient is actually is the MCS. It's actually this shock team, and the care that happens outside the cath lab.
Dr. Abdullah, just a small question, I think, and it needs to be addressed because everyone works in different hospital with different budget, with different availability. The question is to Dr. Haider, because I know in your place, maybe you have, the question is regarding the LAVA ECMO, which is the left atrial veno-arterial ECMO. It's better and cheaper option than Impella. What do you think about that? And I want to hear also from our panelists.
So excellent question. So two comments. One on the comment about the lactate. I'm in the presentation, I misspoke. I said every 6 hours. Initially should be every 2 hours. And the communication between the CCU critical care team, both on hemodynamics and on the lactate clearance. And with regard to LAVA, I think the answer is yes. We actually have one of my new colleagues, Dr. Zaidan, who is now our director of Heart Center, has significant experience with it. So the answer is yes, but show me the data. So the only thing that we have seen so far is Impella CP. And I'm really looking forward, Professor Abdullah was saying, what else? I think there are several AI algorithms that I think will, if they pan out, they will be very helpful. And second is the smaller devices. So just imagine the danger shock trial with the same benefit, but without the 8% vascular complication risk. I think the difference would be huge. So team approach, I mentioned, role of AI algorithm in monitoring and mobilization, and 3 smaller devices. I think those would be, for me, the key to success going forward.
Dr. Haidar, actually, I want to add one more thing with you. You're very expert for this kind of issue. So for the mild shock, we are using the IABP. But what is the pinpoint? Which one we can choose for the Impella or the ECMO, like a severe LV failure, we can use the Impella, or cardiac arrest, we can use the ECMO. So in your experience, what is your comment for the ECMO and the Impella, how we can pinpoint differentiation point, which one we will use? Because IABP is commonly used for the mild shock, it's fine. But Impella and the ECMO, it is little bit. So please give your comment. Thank you, sir.
Sure. So So that's why, when I showed the negative trials of ECMO and on balloon pump, I mentioned that it based on the patient that were randomized. Full disclosure, I still occasionally use intra-aortic balloon pump, but if I use it at an earlier stage, I think Mohanad made this point. MCS, whatever MCS we use, it should be done early, otherwise it would be too late to do. To me, utilization of ECMO would be in the setting of biventricular failure, and especially combined with respiratory failure. I think those would be the case that you could potentially reach out to ECMO as your support system.
Yeah, don't forget also the ECMO is being used more because it's much cheaper in many places of the world. Impella might be better in the way you do it, but ECMO, depending on which one, the lava is much cheaper to do, and I know it's been used many places, and it does give you, okay, a randomized trial is not there, and I think it's going to be difficult to have a randomized trial that way, and it probably will never happen, but it is being used because of cost issue with the Impella.
Okay, thank you very much.
I'd like to hear your comment as well, because you guys using both actually, ECMO, Impella, everything in the. So maybe your comment before you introduce the next speaker as well.
Well, we know as the most commonly we use, of course, as agreement with all others, the catheter, the PE catheter is very important when patient in CCU, because that will give you impression to escalate or de-escalate your devices. We go simply, for the time's sake, if he has in the shock with the balloon, because it's very easy, and we see if there is no improvement, we escalated either to ECMO or the Impella. But most often, if we don't know about the whether there is big anterior wall MI, there is a possibility of thrombus and LV, we rather not to put Impella unless we know that there is no evidence of LV thrombus. But what we do, we put balloon, no improvement, we go to ECMO. We should introduce.
It's automatically come by your team, Professor Abdullah. It's not by me.
We should,
they automatically come
nice.
by the.
I went
by
very
team.
fast. I was very fast. Anyway, it's really glad to have you, Dr. Misbahul Ferdous from BJ China. He is the Vice President of Asian Society of Cardiology, and it's too late in China. I know that. We appreciate your presence with us, and he will give us a talk on the dissection, the state of art. Please, Dr. Misbahul, now you can address your talk.
Bismillahir Rahmanir Rahim. Thanks, GIS, for inviting me for this prestigious conference. Each and every year, I'm very excited to join the complication and complex case show, because I'm also learning a lot of things from this conference. So today I will discuss about the dissection, the silent tear, how we can avoid the dissection, and if it has happened, how we can manage. We will discuss many things today. Next 15 minutes, please join with me. Thank you. My name is Dr. Misbahul Ferdous. I'm from Fuai Hospital, which is the National Center for the Cardiovascular Disease, Beijing, China, and one of the largest heart centers in the world. I'm also hold the Vice President position for the Asian Society of Cardiology, and I'm Associate Editor of the US Cardiology Review Journal. Let's refresh our memory. What is the coronary artery dissection? It's a tear in the coronary arterial wall, allows blood to enter and propagate within the vessel wall, creating the false lumen that can compromise the true lumen flow. There is some risk factor important for this dissection: scar, physical exhaustion, emotional stress, and iatrogenic. And there is some right side you can see it's a mechanism like a dissection, luminal compression, ischemia, and which can lead acute coronary syndrome, arrhythmia, heart failure, sudden cardiac death. Coronary artery dissection is a mechanical and iatrogenic risk factors. Understanding the mechanism of arterial wall injury and dissection to prevent a life-threatening complication. There are several causes, but number one cause is catheter trauma, which is very common. Intimal tear caused by catheter or guide wire, creation of a false lumen within the vessel wall. Severe calcification, like a rigid circumferential calcified plaque, also can lead the dissection. Plaque rupture also. Recognition of this risk factor and careful technique during coronary interventions are essential to minimize the risk of the coronary artery dissection. Immediate assessment is very important. Rapid evaluation, informed treatment, improve outcomes. Any kind of dissection happen, first of all, we need to check the ECG assessment. Assess rhythm, rate, conduction, identify the ST segment elevation or depression or neo LBB. So hemodynamic monitoring also very important. Assess BP and organ perfusion, identify the hypertension or cardiogenic shock. And TIMI flow also very important. TIMI 0, 1, 2, 3. So which can lead the early detection of the complication. Immediate assessment also involved in the two sides. One is microcatheter angiography. Another one is a IVAS or OCT finding. What is the actual microcatheter angiography, which define the true lumen and false lumen, assess extent or dissection, guides optimal wire and stent strategy, minimize risk of propagation. Microcatheter injection provide high resolution visualization of the true lumen and dissection anatomy. IVAS also can give you a better picture, and OCT also can help to understand the dissection area. Combined use of angiography and intravascular imaging ensure accurate diagnosis and guides safe, effective management. Coronary artery dissection, there is some kind of classification like a linear radiofluorescent flap, double lumen, contrast staining, abrupt cutoff, progressive, or sudden occlusion. So there are some pictures. So how it can be classified like A, B, C, D, E, F. Coronary artery dissection, there is an algorithm. So how we can manage? Number one, recognize and stop the injurious maneuver. Stop forceful contrast injection, because the contrast injection is the one of the cause of the dissection. Catheter manipulation, immediately stop. Assess the clinical and angiographic status, like a TIMI flow, or patient is condition stable or unstable, need the urgent action or need other planning or CABG, we can also assess. Minimize the further injury. Flow preserved and patient need to be stable. Flow compromise or high risk feature like ongoing ischemia, hemodynamic instability, left main, proximal large vessels involvement. So also need to think carefully. So there are also some strategy like a PCI approach or surgical approach, anticoagulation therapy or documentation and follow-up also very important for coronary artery dissection case. Coronary artery dissection during the PCI also need to think how we can handle like a guiding catheter trauma or stiff guide wire injury, retrograde wire withdrawal, or left main occlusion risk. So all actually can be happen during the PCI. So preventive measures also very important. So inject contrast gently, avoid forceful high pressure injection through the guiding catheter. With a 5-inch child catheter, gently we can push, and consider the advancing the 5-inch cannula slowly over a balloon catheter for control atraumatic delivery. So the most important is the assessment and take the right decision on the right time. There is some special scenario in the dissection case. Left main or proximal large territory dissection, this is a high-risk hemodynamic collapse. Urgent intervention is required. Urgent stent to seal the entry tier and restore flow. Emergency CVG is sometimes need. So the side branch dissection during the CTO retrograde, protect the donor vessel, or myocardium at risk is large. Protect the donor vessel with the microcatheter during with the exchange. Withdraw the wire gently to avoid the propagation. And coronary perforation, also very important, like how to manage like a prolonged balloon tamponade, covered stent implantation, emergency surgery need or not, also very important to know. The key message: timely recognition and appropriate strategy in this special scenario are essential to save myocardium and improve outcomes. So coronary artery dissection PCI technique principle, like where the true lumen use a microcatheter stent strategy, also very important to understand. And there's a many poster I create. So I declare myself all the poster. This is created by me, not from the some kind of online, internet, or published article I use. All the presentation slide prepared by me. Thank you. So also there's another technique like for the.
Okay, so excellent, Ms. Mahul. Thank you very much for that. My question is to the panelists here. You know, if just for because we are learning, you know, it comes from experience, of course. The more experience you are. So I want to hear from everyone here. So if you anticipated, you know, a dissection of left main and patient is stable, what do you do next?
It all depends, my friend, on where the dissection is. Is it at the entry of the guide where it's sitting? Is it extending beyond the left main to the LAD or the circ? Because that will affect your approach for sure. But either ways, there's always a saying from the old times: dissection treatment begins with the entry. If you close the entry, then you take a deep breath. After that, you can do whatever you want with that dissection. Closing the entry in the left main is the first thing everybody should do, even if it's extending beyond the left main to the LAD or the circ. You have to close that entry area.
Dr. Abdul, actually, my case was the left main dissection, so it's ongoing. It's left main dissection. Yes, please.
Okay. Anyone else? Anyone input?
In dissection, since we are using a lot now of DCB, we are creating dissection. We used to be afraid that every dissection we should cover it. Now I have a lot of cases that I made dissection and it looks horrible, but the artery-3 patient, if asymptomatic, no hemodynamic changes, I left them, and then I did later on relook angio. They healed completely with a very nice. So is this the dissection will go into our rules that if there is a limiting flow or hemodynamic, then we should cover it. Otherwise, a minor dissection with TIMI-3, completely patient asymptomatic without hemodynamic changes, I think we should leave it to give a chance to heal.
Dr. Musa, are you talking about the left main dissection or the other
No,
dissection?
not left main. We don't use nowadays DCB for left main, so we don't create dissection.
No,
but
we
that's
have.
apply
We
for
have.
non. Yeah.
Ms. Mahul, how many cases we have now, left main?
Yes. Actually, you are in middle of my case.
DCB.
DCB actually we did in the 2019 in Taiwan, China. We did the one DCB is a 29 years old. Guys came for not dissection, is a AMI patient. We did the left main dissection. So I sent the guy to the GIS conference. So can we proceed with my presentation? It's
Yes,
middle of the presentation,
yes.
please.
Yeah.
Thank you. Imaging guidance like IVAS or OCD we can use. For the ostial dissection need to be very careful. Avoid deep intubation, use careful catheter engagement. Stent may need to extend into the aorta or in ostial cases. Then we can plan accordingly. So let's talk about the today case. How we can define like it's a 51 years old male, past history, hyperlipidemia, hypertension, and diabetes mellitus. Clinical history, intermittent chest pain for 1 year. And case characteristics is a left main dissection. And how we handle and what happened during the procedure we can discuss here. So it's the CAG confirm like a left main distal segment 50% stenosis, LAD proximal segment 90%, LCS 70%, PDA 90%, and LED diameter is smaller than the LCX. These are the common scenario of the angiogram. When we look about the angiogram, we feel it's okay and it's a not very complicated case. So let's do it. So using an XP catheter, the assistant manually injected contrast medium, then left main dissection occurred and the hematoma extended to the left coronary sinus. The clean cut case convert to the nightmare, not for the patient, for the me and all my team. So we are not panic that time. We know what to do and how to do. So we can show you one by one, step by step. So the EBU 3.5 guiding catheter were exchanged and the BMW guide wire were advanced to the LED and LCX respectively. So the balloon dilatation done with the 2.5 mm balloon. So LM to LED, the stenting done with the 3 size. And the ballooning also crash technique done. So left main to LCX, like 3.5 stent done and rewiring technology also done here. Kissing balloon dilatation following separation and post dilatation also done in this stage. So contrast medium continues to spread into the left coronary sinus via the left main dissection. So we feel, so what we done not perfect, or maybe need to do the more checking by the IVAS. So we are pursuing the IVAS to check the inside what's happening the dissection wall. So IVAS indicated incomplete expansion of the proximal segment of the left main stent, and the stent edge failed to cover the entry tier of the left main dissection. Then we put the stent in the left main ostium, and we feel now we are in the safe zone. So IVAS indicated, again, we did the IVAS, then IVAS indicate good extent expansion. The distal end of the left main stent covers the entry tier of the dissection. So I think the final picture is acceptable. At least we secure and we save the patient hemodynamic condition and the coronary artery and the dissection that stage already covered. So I think this is acceptable in this time. So patient come for the follow-up and stay in the hospital long time. So ultimately patient get back to the home with the safety margin. So aortic coronary dissection, the home message, a rare but life-threatening complication, and management guided by the vessel patency and extent, like a treatment strategy depends on the patency of the distal vessel and the extent of the proximal retrograde propagation of the dissection. Mechanism of recognition, how we can manage, typically caused by the various contrast injection, balloon dilatation, and non-coaxial engagement of the guiding catheter with the coronary ostium. I think most of the dissection case, at least 30 to 40% done by the heavy, forcefully contrast injection. So we need to think carefully before we put the contrast injection. We need to think about the hemodynamic condition more and more. So immediate ostial stenting also can be one of the choice. So excellent prognosis with the conservative pair. A localized aortic dissection, once sealed and stable, carries an excellent prognosis when managed with the conservative watchful approach. This is the summary: prevention and management of the coronary dissection, like identify high risk lesion in angiography, look for the long lesion, calcified lesion, tortuous, need to think about more and more. Select appropriate indication, select appropriate guiding catheter, one of the most important. Consider anatomical lesion characteristics, operator experience to ensure adequate support. So pay attention to the guiding catheter torture during rotation. Monitor the pressure before injecting contrast, very important for all the PCI time. Select an appropriately sized balloon and a stent. Determine the management strategy. Use a dual lumen microcatheter and IVAS, ensure hemodynamic stability. So we prepare, plan, prevent, and protect the coronary artery. So I think if we can think all the management protocol, the coronary dissection can be avoidable. And if something happened in the PCI time, so if we can manage properly, I think we can make the safe zone again in the PCI time. So a special thanks to Dr. Sakif Sharir and the Tariq Ahmed for helping me all the time. So I'm very happy again for the joining this conference, inshallah. And I'm very happy also to inviting all the colleagues and the doctors and cardiologists from the different world to join the Great Wall Conference 2026 in October, which will be held in Beijing. So welcome to the Beijing. Thank you.
But inshallah, we'll try. Musa Akbar, aortocoronary dissection is, what should we do? As we stop, make it worse, or what should we do?
Well, I was going to ask him for Dr. Misbahul that when you have osteal dissection, you stop injection because that might propagate the dissection, and we have seen that. So do you use the guide linear extension in that situation if your lesion is also beyond the left main in the LAD to measure the extent of the lesion? Therefore, you cover the lesion from left main to the left, from LAD to left main.
Actually, a guide extension can be used with this very safety margin. It's not normally used. It can be the bailout technique. So normally we don't use that kind of, we are in the risk already. So like a guide extension can be more worse than nothing can be left in our hand. Thank you.
Yeah, because we learned that. Sorry,
Mohamed, I mean, that case of Misbahul is really, life-threatening. So how would you approach that one?
The dissection could extend toward the aortic cusp, then you have severe aortic regurgitation. So the first thing to do, as just mentioned, you stop injecting very hard. And if you are going to inject, you kind of, with the wire, you wire your artery and you move your guiding catheter out, very gentle injection. And the first thing to do is just put a stent in to seal the entry point. That's the most important part.
I want to add something like that case, actually our last case in that day, my fellow, he is the first case and very excited, just push the.
Yeah, I mean, this is what happens.
Finish.
Hard injection, yeah.
So so the careful injection is very important for this kind of prevention. I think we need to be more careful when we are starting that kind of high risk procedure. Yeah. Only small dye can be destroy everything. Yeah. Then it took more than like 2.5 hours to finish the case. Alhamdulillah, everything's fine. Thank you.
So I mean, this is what I'm saying. It's just when it is the guy does not coaxially inject very hard, and this is what happens. So the most important thing is to seal the entry point.
Let's get a quick one from Hadi. Then Thani, you can introduce next speaker, please. After Hadi.
Dr. Misbah, beautiful case. Let me ask you just what was the thinking on your part that you changed the guide and then you put another guide and put 2 wires in? I personally wouldn't have done that, but I'm trying to figure out why you did that.
Yeah, actually, in my plan that time, I want to make it safer because when my fellow did this, I have like only things if I don't have the more strong hand in the guiding catheter, like maybe something wrong more worse because I know it took long time. So we need to in the safe zone. So that's why we changed the guiding catheter. I think I did the right track that time. So that's all. Thank you.
Were you going radial or femoral? I didn't. Was it radial or femoral?
Which one?
In that case.
It's all radial, but we start with the femoral sometimes.
Because I mean, I was going to ask the same question, but I thought it's done and dusted. You can't argue with success, but it can be catastrophic. because sometimes the guide could be sealing or holding that flap. So the best thing to do is just to wire it and then control what you need to do. If you need to, you could go a ping pong, but to move the guide, I mean, as I said, it worked and you're very experienced and you do a lot of these cases, I'm very comfortable. But for the general audience, so something like this happens, please try not to move the guide and try to wire the RT gently to make sure you don't lose it. Because if you move the guide, that left main could easily go. But I said, you must have seen it, you know that it's okay, and you could have seen it, assessed it nicely, but for the general audience who are not as experienced, please don't change the guide. You wire and you control that dissection. Once you put the stent in, you could, if your guide is not working very well, then you could change it, particularly with the radial approach. If you have a spasm and you take the guide catheter, you put it in, adjust, can be 10, 15 minutes, and who knows what the outcome could be. But as I said, with somebody who's experienced, you could handle it differently and you could succeed with that. But for the general audience, I think I would be a bit careful about changing the guide.
And also, I
Excellent
want to
point.
add all the young doctors, if you want to add the coronary dissection in the left main, should be discussed with the emergency, the hired people like a big boss. Otherwise, it can be more messy situation. Thank you.
Thank you, Dr. Musbah. Next speaker will be Dr. Faisal Goufi, interventional cardiologist and chair of cardiology in Johns Hopkins Aramco Healthcare in Dhahran, Saudi Arabia. And the title of the talk, Large Pore Vascular Access Complications. Please go ahead, Dr. Faisal.
Assalamu alaikum. My name is Dr. Faisal Goufi. I'm an interventional cardiologist from Johns Hopkins Aramco Healthcare. It is a great pleasure to be with you this afternoon, and my sincere thanks to the GIS for putting together this excellent and exciting webinar. Over the next couple of minutes, I will be talking about the vascular large bore access, giving you an overview of how we progressed over the last couple of decades in relation to vascular access. I have nothing to disclose in relation to this talk. I'm going to give you an overview of the vascular access and journey for success. So access choice is not just about convenience, it's actually about survival. And as you will see in the next couple of minutes, that there has been great advancement in the research to show that the selection of the access is very important in achieving better patient outcome and reducing mortality. So I'm going to start with some historical perspective. Over the last couple of years, specifically a decade, there has been a great shift in the most common procedure done in the cath lab, which is diagnostic and angioplasty from a radial to a femoral approach. This change in the access from radial to femoral approach has corresponded to a significant change in mortality in a direct and an indirect way. This data that I'm sharing with you is from a meta-analysis of 7 randomized trial that combined patients. Nearly 32% of them were female, 95% of them has acute coronary syndrome, 75% of them were angioplasty. And when you look at their cumulative mortality, there was a significant difference between femoral versus radial approach with a bleeding risk of 1.5% in the radial arm versus 2.7% in the femoral arm. This relationship has been either a direct relationship in reducing the major bleeding risk, or indirectly, which will affect mortality in a positive way by reducing major bleeding. Despite this clear evidence that the radial approach is the way to go for most of the cath lab procedure that require coronary intervention, but for a variety of reasons, there's still, by 2024, almost 30% of those procedures are done femorally, and this might be interpreted in a way related to either learning curve or sometimes the use of the chip procedure and the requirement for equipment that might not be suitable for radial approach. Having said that, the use of the radial approach in the cath lab setting, and as I will show you later in the slides, as also an alternative access for some of the structural procedure, has been shown to reduce major bleeding and in an indirect way death, but there has been a signal that the risk of stroke has increased with the use of radial versus femoral approach. I'm going to start by sharing with you a case that demonstrates that large bore axis is actually a combination of a large bore and a small bore axis. This is a straightforward cath procedure, not ultrasound guided, 6-French system. The operator tried to use perclose. The perclose failed with what you can see in the left side of the screen, stenosis and also an extravasation at this side. And you can see it nicely demonstrated here. Now, a theory behind that could be related to the deployment of the perclose that can induce injury as the person is pulling back the perclose in a calcified plaque, because you could see the effect of the perclose at the insertion site causing a stenosis and achieving hemostasis at the entry, but yet there is a site of perforation above the entry site. So the usual technique that's usually used in those situations is probably to dilate the suture side and achieve homeostasis by prolonged balloon inflation. And that's what the operator done in the first part of this procedure. 2 hours later, the patient hemodynamically unstable, brought back to the cath lab. And as you can see, the site of the entry has been sealed, but the issue that is likely related to the injury caused by the perclose higher than the insertion site persists with extravasation and perforation. Now, the patient was treated successfully with a cover stent and subsequently left the hospital. But this case clearly demonstrates that while we are dealing with large bore axis, there is still the required skill and safety related even to a small bore axis within the cath lab. Just to share with you how it was, this is the source registry in 2020, 2012, looking at vascular complication in all comers. And as you could see, the risk of such vascular complication has been significantly high. This is not a randomized trial. This is real-world data after the expansion of the TAVI since 2010. And still, almost 1 in 5 patients is getting a major vascular complication. Now, what are the first predictor of a vascular complication that has stood clearly in the literature is what we call the sheath to femoral artery ratio. And this has been clearly manifested in the CT analysis. And this is actually one of the advantage of adoption, early adoption of CT scan in planning the axis versus the old femoral angiogram. And if you have a sheath to a femoral artery ratio, and when we are talking about the sheath, we are not talking about the inner diameter, we're actually talking about the outer diameter of the sheath, to a femoral artery more than 1, this clearly corresponds to a lower vascular complication. And if you look here, VARC, major complication, when you have a vascular sheath to a femoral artery ratio more than 1 or 1.05, is 6.9% versus 30% for those who have less than this ratio. And this has also been corresponding to a similar 30-day mortality related to the major vascular complication. Another publication that has focused not only in the femoral axis, but also in the whole femoroiliac axis, and it came up with a ratio of more than or equal to 1.1. If you are reviewing a case for a potential structural heart disease procedure that involves the femoral artery, and your sheath to iliofemoral artery ratio is more than 1.1, you're unlikely to run in a vascular complication. And this has been clearly shown and only validated for CT scan, not necessarily for femoral angiography. Other factors that over the years we learned that they are important in planning a large bore axis, including vessel tortuosity. There has been multiple description in the literature, but for any operator who are dealing with a vascular axis, any form of tortuosity need to be taken into account before planning the procedure in order to see whether or not such tortuosity will pose any risk during the advancement of the sheath, and whether or not such tortuosity will straighten with the stiff wire. Another factor that is important in planning a large bore procedure is actually vascular calcification. And vascular calcification can be deceiving, especially if we are using femoral angiography. CT scan have better understanding of, first of all, is it a mild calcification within one side of the circle? Is it circumferential that some might need some modification? And these important predictors are better assessed by the CT scan. Now, for calcification per se, whether or not you do have an adequate sheath to a femoral artery ratio, the presence of calcification, moderate to severe calcification, alone has been shown to increase the risk of vascular complication likely related to dissection and poor healing and failure of the closure methodology. One of the important learning skills that we learn and gain over the year is for most of the proceduralists who deal with a large bore access is their ability to bail themselves out, and whether or not they have within their team somebody who do have some endovascular training. And one of the concern when you're dealing with a large bore access is whether or not stenting those arteries, especially if they are crossing the joint, is a safe bailout strategy versus open repair. And this piece of literature came out from the radiology literature looking specifically at a TAVR population who unfortunately, due to a vascular complication, end up with a stent. So an urgent placement of an iliofemoral stent within the study to treat a TAVR-related or a large bore access-related vascular complication did not associate with any short or long-term adverse outcome. So it is one of the bailout strategy that any center who are doing large bore access should either have the capacity to do by the primary operator, or they have access to somebody with endovascular training to bail them out in such complication. So in our quest to improve our closure technique, some of us use the MANTA device basically for the in the hand of the people who really are familiar with the MANTA device. Their reported risk of complication is low, but having said that, the trial that compare head-to-head MANTA versus a suture-based strategy did not necessarily show that the risk of vascular complication is lower with the MANTA device compared to the ProGlide. Now, with the use of the ECMO device and the Ambella device, sometimes we have used the MANTA device when we have to decannulate ECMO in the cath lab versus the OR with great success. Another strategy to improve or reduce the chance of vascular complication, although personally have not tried this myself, is to use a single axis where you basically do the TAVI axis and the alternative axis in the same femoral artery. In this trial, the secondary axis, which is usually lower than the TAVI axis, was not in fact taken by the ultrasound. It was reported to be by anatomical landmark using a 6 French below the TAVI axis. And in this Cleveland Clinic trial, the unilateral axis in terms of the bilateral axis has less chance of vascular complication. Having said that, it is only a single center experience and personally I have not adopted this technique, but it seems very reasonable if we are not favoring the use of the radial axis. So I'm gonna show you a case that I do believe highlight why we need as operator to arm ourselves with technique, and also it highlight the important use of the ultrasound sometimes, although for a small bore axis, the data have not necessarily showed that the ultrasound versus fluoroscopic guidance has made a difference in the small bore axis. This is a case basically where femoral axis obtained without ultrasound, difficult access in a big obese patient. And as you could see, this is the femoral angiogram here, and likely an inadvertent puncture of the inferior epigastric artery happened here with extravasation of the blood. Now, this can be managed with a cover stent if we lack the skill of using coiling. But again, in a diagnostic or a PCI procedure, a younger person, why would we add a cover stent that will cross the joint? So in this case, the use of coils, as you can see here, has been successful to prevent the use of a cover stent. We were successful in establishing flow, and in this specific patient, you could see the beginning of a pseudoaneurysm. There is no extravasation, but this is clearly the beginning of a pseudoaneurysm, and you still see this narrowing. We felt how hard it was to wire this artery, that maybe stenting would be a strategy. A Vyban has been used, and due to the fear of losing the homeostasis, we plan not to post-dilate and to watch the patient clinic and see if you have any symptoms of vascular compromise. This stent can be dilated at a later date. So in summary, for a large bore access, we cannot emphasize the importance of the CT scan in defining multiple factors and predictors that help you to have a successful procedure. The degree of calcification, the size of the artery in relation to your sheath. We had been seeing some CT scan that include thrombi and dissection of the distal aorta that make you change the strategy. Also tortuosity, and whether or not you better choose an alternative access. Having a cath lab and personnel that is equipped with dealing with a vascular complication is important. This might not necessarily be the primary operator, but also you need to have access to a team of either an interventional radiologist or a vascular colleague who can bail you out. Having such equipment, such coda balloon, iliac and femoral balloons, stent graft, and the wires. And more importantly, in my recent experience, when we start to use radial artery as our alternative access, having equipment long enough that can bail you out and for you not to re-stick the left side in order to have a bailout for an endovascular complication. Thank you, and I'm happy to answer any questions.
Faisal, Gofi, and apologies for the, because of the rush of the time, and we had to edit some of your things. But anyway, we're going to discuss this more. So I wanted Dr. Al-Gouf, because he's involved in this area, and the success, I think the weakest link and part of structural is the axis. If you don't do that properly, then everything is gone. You've seen that with TAVI, you've seen with other things. So let's discuss this openly all together with your experience, guys. I just want to maybe bring who's here. Muhammad, you start.
Between a successful outcome and a wrong one. So it is, we're building a huge experience right now. The same thing we were talking about mechanical support device. It's the same thing when you're using Impella. I used two 8 French angioseal for the Impella for the long time, and the series and the publication again is under review. But it is something that you really have to master, really have to know how to do it. Ultrasound guidance, particularly for the TAVI to avoid calcified area, etc. You're dealing with elderly population, dealing with people with a lot of disease, and also knowing how to use covered stent, how to use coils, all helps you to kind of achieve a good outcome.
Bahul, in China with the high volume, you use, so is the entry is nice, calcium and the pathway, of course, with that. How much CT you use this? I know it's mandatory, but in your
100%.
Right, okay.
Right to the point.
100% plus every single case we do the ultrasound puncture.
Great. Thank
to
you.
make safe, because TAVI is good, but the puncture site gone, then many complications we face in early stage of the TAVI 2018, because mainly we are working for the TAVI team. So we have a great experience. So ultrasound is a very simple things. We just bring the ultrasound machine and we do the puncture, and the 100% CT also give the very clear idea. Also, we are using the AI for the whole procedure. So it make us very safety now. So like in another level. So we just build up our own AI system for all the issues. Thank you, sir.
So sorry, just elaborate, because that's quite interesting. How are you using AI? Is this based on the CT scan or is it based on the ultrasound, or how are you using AI?
CT.
Sorry?
When we get the CT or MRI, we put all the slide to our AI system. Then they give us the very clear idea where is the pinpoint marking, what to do, what is the size. It's a huge big. We put more than 1,800 TAVI system inside our AI. So it's a very heavy AI right now. So most of the time,
what's your complication rate after using the AI?
AI actually not for the complication. AI is good for the taking the decision more faster track. Like before we do the TAVI, we have a very big team. Minimum 4 to 5 department need to adjust together. But with the AI, it's make more faster track. No need to bring the many people for the making the decision. What size? What is the entry point? We need to discuss with the cardiac surgery team. No, but we reduce the complication. We are faster track for the taking decision for the TAVI size and what to do, how to do. So AI makes more effort, reducing the time, reducing the complication, give us the more effort, and the small team can do many things.
But we don't know if it reduces the complication, though, do we?
Complication means like a puncture point, what to do, how to do, so we can have the clear idea. So when we put our CT or MRI report inside our image circle, so they have the clear idea. Okay, you do this, you do this, you don't do this, you do this. So I think how to take the decision by the AI. The most important is the TAVI decision, sizing, valve, location. It have the great effort than the complication side for the AI system.
So, Misbah, I have seen a similar model, and it's actually fed by information from the center. And I do agree that it will help you to decide based on the CT scan whether a site is more tortuous than the other. But what I do not, and what I don't want to see in the future is that AI take the position of the heart team, because there are some other elements.
Wallahi, it's gone. You see, like for the TAVI 2018, we need minimum 8 people. 8 people need to be like a coffee. We need discuss many things, radiographer. Now it's gone. It was only 2 teams. Me and my boss.
We never had that, to be honest. It's just you discuss once the decision is made. It's the CT scan and the operator and the. But anyway, I mean, AI is coming no matter what. But it's using it in the right way and the right place is very important.
Excellent.
No, but that's what I'm asking. Do we have any data that it has reduced it? It doesn't look we still have that yet. And that would be very interesting.
No, actually, last year also we have some presentation for the AI using in the Riyadh Structural Heart Conference. Also, we have the very big data presentation in the 2025 in the Riyadh Structural Heart Conference. We present this case, how many things like how many do TAVI with the AI and how it helped for the future journey. Thank you.
Okay, thank you very much, Dr. Faisal Goufi, for the nice presentation on the vascular access complication for large bore. Now we'll move to a symposium. It's a very pleasure to introduce Dr. Fawaz Al-Berdouli. He's a consultant cardiologist in Mohammed bin Khalifa bin Salman Al Khalifa Specialist Hospital in Bahrain, who will give us a talk on the imaging guided PCI with particular focus on OCT. Dr. Fawaz.
Good evening, everyone. It's my pleasure today to join the GIS virtual meeting, the CompEdge, for the complication course. My name is Dr. Fawaz Berdouli. I am an intervention cardiologist from Bahrain. My topic today is a very interesting and lovely topic. This is one which combines multimodality intervention modalities into the future precision PCI way of dealing with intervention. Without further delay, my presentation today, there is nothing better than discussing this topic with a case. And this is a live case. 2 years back, a patient who presented to me a middle age, was planning to go to meet his friends in a coffee shop where he had an anterior wall MI. He actually came to the cath lab, we fixed the LAD, but the problem, we had a bystander disease, which is in the left circumflex. The question was here is what should we do with the proximal LAD as well as this haziness? Is this something significant or not? I'm sure that every one of the audience, including the panelists here, they have been facing such problem, and we don't know exactly which modality should guide us better. Should we do a physiology evaluation of the lesion in the proximal circumflex, or we should just go ahead with intracoronary imaging and evaluate that? Or probably some other group of interventionists will just go ahead and stent it, and probably the last group would probably leave it for medical therapy. What we're looking here in 2026 is to have a proper evaluation of a lesion and have a scientific rationale behind each and every treatment we decide for. So when you have the circumflex haziness, either you go for physiology or imaging. This has been a debate for quite some time. People used to think that physiology and imaging are competing each other, but we always say that they are complementing each other. There is no doubt that physiology assessment will help you into evaluating whether this lesion needs to be intervened or not, or deferred based on negative FFR or IFR, while intravascular imaging will help you and guide you of how good your treatment is and what is the size, and if you need to have any debulking or plaque modification treatment. Now, we all have faced this problem, and we sometimes have a multi-vessel interventions where you probably need intravascular imaging on one side, and for another vessel you need to do an FFR or IFR. And today, there is no better way than having to balance these two modalities of precision PCI in one catheter. So what I'm going to show you today is instead of thinking whether you need to use the FFR or the physiology component versus the intravascular imaging, we are introducing the first system to combine the FFR and physiology, mainly the OCT imaging, in a single catheter, single pullback. So the Altron 3.0 has different features and different modalities of looking at the vessel. So beside it looks at the imaging, which is the basic part of the OCT, it also looks at the FFR. So you can combine the physiology and imaging in one modality, in one run, in one pullback. The beauty about the OCT here is that you can, of course, from the Altron 2.0, we have been doing the co-registration. So you can co-register the angiogram, and this is our GPS as an interventionist, with the intravascular imaging. But what is added here is that you can combine also the physiology part, which is the FFR, with the lesion on the angiogram. And then you can have one pullback stating what is your baseline FFR and what is your baseline MSA, what is the morphology of the plaque, and once you treat the lesion, you will be able to calculate the outcome of your PCI in terms of MSA as well as post-stenting FFR. So the new technology has developed in the Altron 3.0 depends on the FFR OCT, which is a computed algorithm basing the FFR on which vessel you're talking about. So the LAD has a different FFR to compare to the circumflex and RCA. So you need to state carefully which vessel you are doing the pullback so that the machine will be able to recognize. The second most important thing is the bifurcation and side branches. Based on the length of your vessel, you will be able to document if you need to do sort of some additional of the bifurcations, so that when you do the pullback, the FFR machine, with the help of AI, will be able to calculate your FFR based on the stenosis as well as the side branches. We have a couple of studies documenting the validity between the FFR wire-based and the FFR OCT. And I think this is the future, where we will be able to have a robust studies and data regarding this topic. And to keep this topic really enthusiastic, I thought of sharing with you one of my cases that I have done, and I want to show with you how this has helped and guide my decision during the intervention for this case. So this is a 76 years old dyslipidemic patient, smoker, referred with positive treadmill test. He has done a CT coronary angiogram in another hospital which showed mild to moderate disease. So we brought the patient because of the treadmill positive, and his circumflex was really non-significant lesion, as well as the RCA, but he has this LAD tight stenosis with quite big diagonal as well. Obviously, you can all appreciate that the stenosis is very significant in the bifurcation Medina 111 between the LAD, or probably 110 between the LAD and diagonal. But there is also a lesion proximal to that, and probably that is where the septal is coming, which looks moderate, and so probably in some angulations, probably moderate to severe. So if we analyze this picture, we have two lesions, one on the blue, which no one of us has a doubt that this is very tight, and the one in the red, which seems to be moderate and probably is severe, where the septal is coming out. And the question is, treating that is, the blue one is not really a brain, it needs a brainer, but the problem is, do we need really to treat the red segment stenosis here or not? So one option is we go and treat focal stenting between relatively healthy, proximal to the diagonal origin to the distal, with minding up that there is a discrepancy between the size of the LAD, or we go all the way and include the proximal moderate to severe disease, and this will be a longer lesion, or probably there is also all the way we need to go to the proximal or ostial LAD. So this is a decision maker during the procedure for every interventionist when he looked and analyzed the angiogram. Now, all days we used to decide, and this is probably the way to go, but when now we have a multimodality imaging during the intervention, we can do a multiple things. So I'll tell you what I have done here. So I run the OCT catheter, and I'm going to run this for a few things, and I'm going to show some of the modalities that you can see. So you can see on the right upper quadrant, you can see the intravascular imaging. And on the left side, you can also appreciate that there is the co-registration by the angiogram. And you can see the cursor, which is the white thing moving, which correspond to what we see on the longitudinal down the images. So if we stop this at this point, and we try to go, this is the proximal LAD, because you can see there are two wires actually, one at 11 and one at 1 o'clock. And then as I go proximal, look at the cursor, the white cursor in the angiogram, you can see it is moving, and it is corresponding to the area that we have a problem. And look at the area here. It's 1.3 MLA in this area, which we thought, at least myself, that could be moderately diseased, not severe. But definitely with this area, it is definitely severe. And then you can appreciate that there is some stenosis here, and then relatively healthy vessel. And then it goes again, and it divides. It goes very tight here with some of the calcification. You can see the monitor there on the angiogram, on the cross section, where the diagonal is going out. You can see that we have two wires, one at 12 and one at 9, and the one at 9 has disappeared, went to the diagonal, and this is the continuity of the LAD. So what we got from here, that we probably have two areas of tight stenosis, one that at the diagonal and one at the septal origin. Now, the beauty of the Altron 3.0 is that the same run we can ask them to do for us the FFR. So you can see that the FFR here goes red, which is very significant, 0.69, less than 0.7, and it goes all the way involving the lesion at the distal diagonal as well as another lesion. So you can see there is two step up, one at the diagonal and one at the septal segment. And the beauty of the Altron 3.0, it tells you that if you have this lesion and you treat it only you treat the distal part, your FFR will improve from 0.7 or 0.69 to only 0.74 because you are leaving the other step up. While if you do planning to involve both lesions, which is a longer stent in this case, then your FFR will improve from 0.7 to 0.91. So definitely we decided to go for a long coverage stenting from the distal good landing zone, distal to the diagonal, all the way to the proximal segment of the LAD, where there is a relatively healthy vessel. And this was the initial angiogram with the OCT after the intervention. You can see the stents there. There were a little bit of a malapposition in the ostium or the beginning of the proximal part of the stent. But then you can see that the stent is well apposed with no edge dissection. So the MLD that we used initially, now we use the max after that, we know that there is a no malapposition, no good expansion, and no medial dissection. But the apposition only in this segment where the bifurcation is relatively low. And at this point, we ask the Altron 3.0 to tell us what is the FFR. In fact, the FFR has improved from 0.69 to 0.93. However, if you can actually get an improvement of the vessel. So what we did here is we went and postulate the lesion further, and that is what we got at the end. So you can get very well expanded stent, good MSA, everything above 5, as well as no edge dissection. Beautifully also, one extra feature of the Altron you can notice here is where I'm going to stop now. You can see there is a blue marker here, which is something new in this Altron. It's actually detected the lipid. So once you have a lipid-rich plaque, you will be able to see that. Obviously, this is going to be a very helpful, especially for those who are really not being able to differentiate between the different modalities or the different morphology of the plaque disease in the vessel. So when we repeated the FFR, after postulatation, the FFR has improved to 0.94, which is very normal. And this was the final angiogram after the stenting and postulation. So my take-home message here from this brief presentation is that the angiogram is our GPS, but in 2026, this is not enough anymore. The physiology will always help you to answer the question if we need to treat the lesion, while the imaging will guide you of how to treat it carefully and precisely. We always have the doubt of how to integrate both, but I think the future has come with a good integration between the physiology and imaging. And this is going to be a beginning for a future, what we call as a precision PCI. With this, I would like actually to end my presentation. I'm more than happy to receive any further comments or questions. Thank you very much.
It was excellent, very practical things which should happen in most tertiary hospitals who are practicing this. We don't want to see it in the conferences, but I hope this is the case happening at every tertiary hospital. But let's come back to our practice nowadays. How many of you use these modalities to approach that case, or you've not just treated that medically? Anyone? Muhannad?
I mean, it's a case by case, really, to be honest. You can't. We're using intravascular imaging. Certainly, Ultraon 3 is a fantastic addition. There's a lot of information overload. You have to be practical. You have to be judicious. So you don't have to pull it every time and you do it. Otherwise, and we always say, if you want to do the procedure, you do intravascular imaging. If you don't want to do it, you do functional assessment or pressure wire. So really, it's a kind of really clinical judgment, but it certainly has added a lot of information and a lot of, and remember, there's a patient in front of you. Numbers do not give you all the pictures. You have to be judicious in how to do it. So I know this is kind of a generalized answer because that's the truth, to be honest. You don't have to do it in every case. There are cases, if you're in doubt, absolutely, this is very, very helpful. And long segment of disease, this could be very helpful, but you might end up doing more than you wanted to do when you do the imaging. So, you know, it's building your experience and learning from cases such like this will help you in the long term.
Musa Akbar, you are working in, again, similar to Dr. Fawaz.
Yes.
I'm sure you're using physiology imaging. And I like the way the Fawaz done it, but I hope, you know, everyone wants to use this tool, use it in this way, because people are having the tools, but not using that much. Tell us your experience.
Imaging is showing in all the trial, which I will show you at the end of the talk, the evidence behind it, all the trial showing that it is a superior to image-guided PCI, angiography-guided PCI in terms of target vessel failure. And very important, as Dr. Muhannad said, not in every case, but in particular some cases, complex lesion, very long lesion, calcified lesion, unprotected left main. These are where you do the imaging, very important to help making your easy procedural to be done easily, and then to have optimization of your results. At the end, you will have a less in target vessel failure, repeating revascularization of the future. So imaging, of no doubt, now is becoming a class 1 indication in the situation where I mentioned. And we do it in these situations. For left main, I think it's very important to do it, because especially if you decided to do 2 stent techniques, I think imaging is considered to be essential, if not mandatory, in these situations.
Beautiful. Fawaz, yes, go ahead. Go ahead, yes, please.
This for each and every case, because this is going to be a waste of time, waste of resources. And when you need it for other really necessary patients, you're going to lose it. And that's the take-home messages for the audience. Now, the Ultraon 3.0 has been introduced, or at least I received it in beginning of July. So I actually wanted to test this because I was having a big doubt about how confident I can I trust the OCT FFR, or what they call it, a virtual FFR. And unless I got it trusted, I'm not gonna present that. So what I have done is actually in the beginning of the cases, I was testing with NFFR and the OCT FFR. And I was actually looking that things are actually pretty similar. And I went actually into literature review, and there was a fusion study. So the fusion study, they actually compare the virtual FFR with the wire-based FFR, and it was quite similar, but the numbers are very quite low. Mind you that all the studies were from the US, and it is an FDA approved from the US. I think the number was around 200 patients. There's one case or one study, but it is single center in Poland, again, was measuring the wire-based FFR compared to the virtual FFR. Now, over the last 1 month, I have been collecting quite good numbers. So I have 15 cases, including a bifurcation, left main, tandem lesions, because I think this is where really OCT, and because most of the time you wanted to open a catheter that helps you for multivessel PCI, but you don't want to open an FFR on one side and then you open an imaging catheter on the other side, because again, you look at the budget. So I think the new AI introduced in the OCT FFR has helped a lot, so that we can calculate the FFR or the virtual FFR without the hyperemia. Now, still studies, we don't know what is the virtual FFR in ACS, because no one of the studies that has been done were on a patients were ACS. But anyway, this is the future of the game. So we need to know exactly what will happen in the future. But definitely, the other features of the Alteron, from my experience, 3.0, we are using less amount of contrast. So one pullback of this LAD was only with 4 cc contrast. So they have what's called as a fast pullback. The beauty of actually getting the good resolution and detection with the AI is much, much better than the old versions. However, again, this is not for every patient. You have to select which patient is going to benefit most. But I think on the long run, instead of having different catheters or different modalities open for one patient, is one catheter can help for both. But still, we need to have more evidence, I think, in the future.
Yeah, the future, I think, is integrating all this to get the best PCI for the patient. So thank you very much. Let's move to the cases now. Thani.
So next speaker is Dr. Musbah.
Because he presented.
He presented the case. We move to the next.
No, I have another case for the complication. There are 2 cases today. One is the presentation. One is.
All right.
The timing to be late in China side. Go ahead.
2 a.m. Inshallah. It's okay. It's okay.
Go ahead.
Yeah, young guys. It's okay. Young guys.
Okay. We appreciate that. Thank you. Go ahead.
Bismillahirrahmanirrahim. Thank you, GIS, for inviting me for this complication and complex case show. One of the really, really great conference for the young doctors. Even myself also, I'm learning a lot of tips and tricks from this conference last several years. So thank you again for inviting me to this conference. So today we will discuss about the complication in the PCI, one of the darkest side. Every young cardiologist need to know one by one what are the complications and how to manage and how to prevent. But if complication happen, how to deal. Today we will discuss in details 1 or 2 points very briefly. So let's start our today complication dark side show. My name is Dr. Misbah Ferdos. I'm from Fuwa Hospital. This is the National Center for Cardiovascular Disease, Beijing, China, and one of the largest heart center in the world. And also I hold the position as the Vice President of the Asian Society of Cardiology last several years. So that's short my introduction. So balloon and stent related complication. So there are mainly 4 points today we can discuss. Number 1 is dissection, perforation or rupture, stent loss, and side branch occlusion. So these 4 are the major complication in the balloon and stent related complication in the PCI time. So today, specifically, we will discuss 2 or 1 point. First of all, the dissection. We know everything about the dissection, like what happened and how to manage the dissection, and the perforation or rupture happen. So critical complication normally done by the oversized balloon, wire or device. So immediate management is mandatory for the rupture time. Stent loss, failure or stent retention on the delivery balloon, or the dislodgement in calcified anatomy requires stent retrieval extraction, either many way. There are many way if the stent loss happen, how to retrieve the stent. There are many way or many technology. Today, specifically, we will discuss all the issues. And side branch occlusion, snowplow effect or plaque shift compromising major side branch during the main vessel stenting. So also we will discuss how to manage all the 4 complications. So, but today we will focus only 1 or 2. So small balloon technique. So single level small balloon with a diameter of less than 1.5. So normally what happens when the stent dislodge? So we put a small balloon in the guiding catheter and we put distally and we inflate the balloon with the small minimum ATM Then we try to retrieve the stent with the balloon together. So we will show you how it happened and what to do. And even everything is done, where is the complication arise? So there is some three-dimensional video we create this. So say, for example, the stent stuck. So then we put one small balloon inside the stent. Then we inflate the balloon and we try to engage more and more. And let's see what is happening. Then we try to pull up together with the balloon. Everything is fine. But now, why the balloon is not coming? There's the tips and tricks. So now we need to engage and angle the guiding catheter a little bit, pull up. Then the catheter and balloon and everything, we can take it out together. So this is the small tips. Even everything is very simple, but when complication happen, so it cannot be on time, it cannot be done properly. So guide-wire winding technology, also one of the smart technology, like if the guiding catheter, like happening something, say for example, the stent loss or the stent something stuck, then we put the another wire and winding technology, like together we rotate very softly, rotate. And once we feel there's a pressure, we cannot do the more wiring, then we pull back together with the stent. This is also one of the smart guide wire winding technology we often use. So here's the some three-dimensional video. So we put another wire. So together there's a two wire. Then we rotate softly and try to engage more and more until we feel more pressure. Once the wire touch the stand, it creates the more vibrant pressure in the wiring system. You can feel it. Once it's stuck, that means no more winding cannot be done properly. Then you feel there's a heavy pressure. Then we pull back together. This is also a smart solution. So now it's stuck, the same situation. Now we need to do again angulation, little bit up the guiding catheter. Then the stand and everything come back to the guiding catheter properly. So the snare is also the one of the smart way to retrieve the stent loss time. So we can show you how it can be done. So the snap technology, one of the easiest technology, like less trouble. And sometimes when the balloon fail, the snare technology fail. The wire technology fail, then the snare technology we can promptly manage. So now the snare technology, see, we catch the stent with the snare. Then we pull back. Every time we did mistake, angulation of the guiding catheter need to be little bit pulled up. Everything come together. Then the solution can be done very easily and without any more trouble. So let's talk about the one real case, the 61 years old male and a diabetic patient and hypertensive. So 14 years history of the chest pain, and 14 years ago, there's a PCI happen. So it's a really complex coronary lesion, challenging anatomy with the severe calcification. The stent delivery failure, the stent failed to cross the lesion despite with the multiple attempts. During the withdrawal, the stent become dislodged in the vessel. This is one of the most nightmare for the cardiologist. And the retrieval technology, we use the snare directly to successfully use the retrieve with the dislodged stent without the complication. And the stent retrieve successfully, procedure complete without any trouble. The stent delivery fail in calcified lesion requires careful assessment. Prompt recognition, retrieval with the snare can prevent complication and the maintain vessel integrity. The most important message from our side, once any complication happen, the operator should become quiet. This is the number one things we learn from our mistake. So any kind of complication happen, the operator should become quiet and think what is the best way to deal. So I think most of the cardiologists who have the great experience, any kind of complication happen, they can overcome very wisely. So here's the RCS stenosis pattern. LRD stenosis is 80%, LCX diffuse stenosis is more than 90%. So we need to think about what to do with this case. So EVU guiding catheter we use and BMW guiding guide wire we put, everything is good. Everything is like a clean planned, what we expecting, everything is done smoothly. But the stent could not pass through the LCX lesion and dislodge at the left main during withdrawal time. Then the real nightmare happened for this case because stent loss, dislodge is a really nightmare for the people, and especially for the LM and the LCX lesion, very closely need to monitor. But hopefully, like in this case, we need to think properly what to do, and we never be panic at that stage. And we done what actually need to done at that time. So femoral artery access we did, and dislodge stent we retrieve using the snare technology and remove from the body. So at that time, I think we did the very right decision. We don't use the balloon, or we don't use the guiding wire technology. We just straightforward, we do the snare technology. And successfully we dislodge the stent, we take it up together. So the femoral artery access, we done the PCI. So after pre-dilatation, LRD stenting also done and implemented successfully. So there's no more trouble after the incident. So summary and the prevention and management of the stent dislodgement. So we need to know what are the actually precaution can be done, can be think before the procedure. Severe stenosis and the tortuous lesion ensure the adequate pre-dilatation. So this is one of the issue. Sometimes we need to think more. Adequate pre-dilatation is very important for any case. So for severe calcification, so use atherectomy, rotational atherectomy for adequate lesion preparation when necessary. I think most of the case, any kind of complication happen, the most important message, the preparation, lesion preparation is very important. It's not about the stenting, it's not about the DCB, it's not about the, no matter what kind of high profile PCI or stenting we are doing, the lesion preparation is the most important key for the success of any kind of PCI. So severe calcification time, we need to think more and more, and select the appropriate guiding catheter to ensure the adequate support. Be gentle when we are withdrawing advancing the stent, avoid the forceful movement. If any problem occur, the operator must remain calm. Keeping the guide wire within the stent is the key subsequent management. Choose the most appropriate strategy based on the specific circumstances of the loss to minimize adverse outcome. So maintain coronary flow. Hemodynamic stability is the top priority for any kind of PCI complication. So I think we understand very properly, like a three technology, like one is a balloon, even the small balloon, very small balloon, but most of the time balloon is really helpful for this kind of dislodgement, and the guide wire technology and the snare technology also very helpful. So I think today we learned some of the case, how we manage. And that's all for today. Hope for the best. And if any question for this case, so I'm happy to answer. Thank you.
Thank you.
So beautiful. You made it so simple. I hope I'm able to demonstrate that in real life. So anyone, any comments? All happy? We'll move to next case then. Khalid.
So we have next is Dr. Hassanin Bishevish, I think, interventional cardiologist from Najaf Cardiac Center, talking about the double CTO complication.
Very nice.
This is Hassanin Bishevish, interventional cardiologist, Najaf Cardiac Center, Najaf, Iraq. Presenting case of double CTO complications. Clinical background. 68 years old male, presented with angina, coronary angio before 1 year showing LAD critical lesion, RCA proximal CTO. Trial to RCA CTO failed at that time. Then, after 8 months, another trial to RCA CTO also failed at that center. Echocardiography showing good LV systolic function. Coronary angio, right coronary angiography showing proximal RCA CTO, blunted entry with long CTO segment and area of calcification. Distal RCA filling from left system through septal collateral from LAD. The JCTO score was 4, which means it is a very difficult case. Our strategy was retrograde via septal collateral. We use Sion black coronary wire with coronary microcatheter, which was successfully crossing septal collateral. Then, after crossing septal collateral, microcatheter advanced, then wire furtherly advanced in the RCA, distal RCA. Due to excessive manipulation with over-torquing of the wire, unfortunately, the wire stuck in distal area of calcification. A trial to untwisting the wire failed. Then trial to remove the wire resulted in wire fracture inside the microcatheter. We used this wire as a landmark. Then we changed our strategy to use antegrade wire escalation. By multiple wire antegrade wire escalation, finally Gaia third successfully crossing the CTO segment. Then after that, balloon dilatation done. After balloon dilatation, drug-eluting stent deployed successfully, jailing the fractured piece of wire. While we removing the retrograde microcatheter, we noticed septal perforation. Unfortunately, we cannot re-advance microcatheter to seal this perforation because the wire was fractured. So what we did at that time, we use another coronary wire crossing a large septal branch from the LAD. Then microcatheter advanced in the distal septal perforator. After that, coil embolization done, resulted in decreasing extravasation, which was helpful. The coil used was a neuro type of coil from Meditron company, EV3. That was the only available coil in our center at that time. Patient hemodynamic was stable, echocardiography showing no effusion, procedure completed. Next day, patient was stable, no effusion, discharge home. Take a home message. Avoid over-torquing of coronary wire and calcified lesion. Septal collateral perforation is self-limiting. Coil embolization helpful in some situation. Thank you for listening.
Thank you very much. Mohanad, anything you want to listen or a message for people who are attending this meeting from this case, please?
That it can unravel. I did notice that there was a significant, in the second, when the microcatheter has gone, it's almost like 180 degree where it across from the septal into the distal RCA. And these are the ones that usually rupture, or quite often the septal split longitudinally. Cases like this, you can leave them. If you do the echo and there's no septal hematoma, you could leave them. You don't have to do much with them conservatively. But yeah, it's about where the angulation into the distal RCA has happened. When you're trying to push the microcatheter in, because of the pressure on it, that could split the septal. But otherwise, And it's also surprising that, I mean, I suppose there's nothing wrong with this going from the start, going retrograde, but sometimes going antegrade from trying antegrade, particularly a case like this where the occlusion is less than 20 centimeter, sometimes it can work. But nonetheless, it's, you know, these, you have to be prepared to deal with these complications if you're doing retrograde, and the guys have done very well.
Great. Musa Akbar, next speaker, please.
Okay, glad to introduce Dr. Ahmed Nada, consultant cardiologist from Ain Shams University, Cairo in Egypt, to present his case, another one of double CTO complication. Dr. Ahmed.
Greetings to all colleagues, extending the greeting to the guest board, Dr. Fawaz, Dr. Abdullah, Dr. Musa, and Dr. Khalid. Pleased actually to join the GIS CompEdge 2026 case-based discussion event. So I'll move to the case. This is a 54 years old male. He's cut smoker, hypertensive, dyslipidemic. He has a history of ACS before presentation. His current angio at that time revealed double CTO in the LED and RCA with circ lesions, and he was offered CABG at that time, but he deferred the procedure. He was kept in guideline-directed medical therapy for 3 months, but still complaining of chest pain. His echo revealed mild reduced LV systolic function with ejection fraction 45%, with wall motion abnormalities. He did viability study, which showed viable myocardium in LED and RCA territories. So the plan at that time to go for CHEP PCI to complex multi-vessel coronary disease. Okay, so this is his angio. Transfemoral approach, spider view showed mid-LED CTO lesion with diffuse circ lesions. Same findings in the lateral view and in the iliocranial view. And you appreciate that there is some collaterals coming to the right. And this is the RCA angio. There is a mid-tight calcified lesion in the RCA with distal CTO lesion, both in LEO view and REO view. And we can clearly see the collaterals coming to the distal LED. So at that time, we were thinking about the strategy, what to do, to go for stage PCI, if so, to start with the RCA first or the LED first, or to go for ad hoc intervention, do the same at the same time, or to rediscuss with the patient the possibility of CABG. Medical treatment already failed to solve the problem. So we went for the plan for RCA antegrade wire escalation. Escalating with the wire, floppy wire, intermediate wire, stiffer wire. And finally, we succeeded to progress with the wire to the distal coronary bed. Started to dilate with a small size balloon, graded to a bigger balloons. And that was the situation after opening the vessel with good preparation, balloon dilatation, intracoronary medications. We got that findings and we went again for more dilatation. And we deployed the stent in the distal RCA, 3mm stent, and the stent in the mid RCA, and both dilated. And that was the final results in LEO view and in REO view. And it's clearly seen improved myocardial plush grade with better collaterals coming to the LED in case we are in need to go for retrograde. So to stop and to evaluate what have been done. So post-PCI to the RCA, the procedure time, it took around 28 minutes, contrast volume around 100 cc. Patient was hemodynamically stable, flat, and comfortable. So the next step to abort or to proceed for PCI LED. So we again decided, after discussing with the patient, to go for LED PCI. So plan to go for anti-grade wire escalation. Again, escalating with the wires, intermediate, leading cross, stiff wire, advanced. Then after reaching the apical LED segment, we, as usual, exchange the wire to a floppy wire and doing dilatation to the LED. At that time, suddenly the patient arrested on VF res, and the coronary angio revealed no flow in left main coronary artery. We did CPR, giving multiple DC shocks, and we were thinking about the cause of underlying arrest. Is it dissection, thrombus, or anything else? We asked to check the ECT, but unfortunately, it was not available. At that time, we gave 18,000 international unit of heparin, 10,000 at the beginning, and 4,000 every 30 minutes. And we asked it to give another 5,000 of international unit heparin. And as you see, we actually extracted a huge amount of thrombi, huge threads, even attached to the guiding catheters. We did multiple flushes, but we couldn't retrieve all thrombi. So we decided to guide exchange, so we could change the guide catheter to a new one to avoid injecting thrombi intracoronary. And we went with two wires, wire in the circ, wire in the LED, and you appreciate that the wire in the LED already went with buckling, as we already prepared the lesion and we were about to deploy the stent. And stenting the left main circ, and that was the final. You appreciate restoring the flow, restoring consciousness in the patients, and the vessel is filled with a lot of thrombi, starting from the left main, extending to the circ, and even including the ostium of the LED. So post-stenting, already the patient is electrically stabilized, no more arrest, hemodynamically stable, and in sinus rhythm. So we thought to shift the patient back to CCU on glycoprotein 2B3 inhibitors. The main problem that the patient complained of short of breath, not chest pain at all. He was congested on examination. So we initiated the full ischemic and failure measures, kept in CCU for a couple of days, shifted to the ward in the third day. His creatinine already peaked at 2.1 and normalized upon discharge. He was discharged on fourth day. We followed up in 1, 2, and 4 weeks. So reviewing some papers published by our colleagues regarding the relation between cut consumption and cardiovascular disease, and extending even the deleterious effect of cut to the nervous, gastrointestinal, and genitourinary systems. And actually, we got that there is short-term cardiovascular events, including acute coronary syndrome, hypertension, and arrhythmias, and long-term cardiovascular events in terms of cardiotoxicity, cardiomyopathy, and heart failure. So my bottom line, double CTO is a really challenge in coronary intervention. Multidisciplinary team discussion is always mandatory in decision-making. Strategy, preparation, equipment, in addition to benign candidates, are the keys for success. Knowing when to stop is the best strategy in intervention. And candid remember that non-targeted issues may complicate the situation anytime. And lastly, experience is to gain more wisdom. Thank you.
Thank you very much, Ahmed Neda, sharing this. I know we learn always, from one of the things I think the expert tells you is to know when to stop. I think that's an important lesson from here. And Hadi, your input here, please.
Yeah, I think, in the literature, when you find a lot of clots in the guide, you always think that the patient is under anticoagulated on the table, or you lift the guide for a little while without flushing it. That's usually the common scenarios when it happens. It looks like one of those happened. Our colleague did not have an ACT machine to tell him what's going on. So it is a very unusual scenario, actually, to have all of these clots sitting in the guide. With 18,000 heparin given and another more given, it would have been interesting to know what, even if there's no ACT, to know what the PTT is when you finish the procedure, to see if it's really pretty high, above 100 or something. So it's a case of either under anticoagulation for whatever reason, the patient is heparin resistant, that can happen. But if the patient is heparin resistant, he would have occluded the right coronary artery already too. So yeah.
Yeah, I just needed to know, how do you give the heparin? Is the doctor with us? How do you give the heparin?
Yeah, it's okay.
Intravenous or intra-arterial?
No. Always we are giving intracoronary. We are giving actually in the catheter itself.
Right, because it is very unusual for this to happen. Very unusual. If they are
That's why I was thinking about maybe
the second thing,
issue.
I mean, when you're doing a CTO, a couple of things here, and I don't know what the practice is. I don't think I've done a lateral projection for 15 years, and so you have to be careful with the radiation, particularly when you're doing CTO. That's and when you're doing CTOs, I didn't see bilateral injection. There was only one. Stiff wires could go anywhere, particularly the current wire. They could cut like in the tissue, like a knife in the butter, and they look like going to the LAD without having a second injection, knowing when your wire is. This is for the general audience, obviously. I mean, the case has been, but yeah, this thrombosis in particular is very unusual. I don't know what the explanation is, and whether after that the event, whether you've tested the patient for heparin sensitivity, for whatever it is, it's just something very unusual.
Yeah, I agree with you actually that usually we are doing bilateral injection just to see where the wire is going, as you mentioned exactly. But again, choosing the projection, it's, as you know, based on experience.
Look, you do what's right for you. However, if you're doing CTOs 2-3 hours, your radiation with any LAO cranial, LAO or lateral or LAO caudal about 6 to 8 times more, and you don't feel anything, but it will affect you on the long term.
You're right, 100%. But all the time we are changing.
Better views for you if you're gonna be doing this on the long term.
Yeah, it's okay. I'm always we are changing projections all the time just to see the proper one.
Beautiful, Ahmed. Khalid Thani, go ahead.
Thank you, Dr. Ahmed Reda, for this great case. Wallah, it was really informative. Next speaker is Dr. Abdullah Ismail, consultant interventional cardiology and structural heart disease from Oman, Sultan Qaboos University in Muscat. And the title, Two Legends, One Valve, Unicorn plus Basilica in a single patient.
This is about 78 years old with diabetes and basilica. Hello, everyone. Thank you so much for giving me the chance to present. Thank you for the course directors and everyone behind the scene. My name is Dr. Abdullah Ismaili. I'm an interventional cardiologist and a structural heart disease specialist. I'm going to present a complex case titled Two Ligands, One Valve, Unicorn and Basilica in a single patient. So this is about 78 years old with diabetes, hypertension, and chronic kidney disease. He has a history of coronary artery bypass in the past and a surgical AVR with a MitraFlow 21 millimeter valve in 2017. This patient presented with progressive dyspnea. He is class 3 to 4. His echo showed LVF of 55%, moderate MR, severe degenerative aortic valve prosthesis with an area of 0.6 and a mean gradient across the valve of 38 millimeter of mercury. This is his left calf before in the workup for treatment. And you can see the prosthetic valve is there and he has patent graft. Here I want you to pay attention to his native coronaries as they are really low-lying and they are really next to the valve. So you get to appreciate once the valve is in profile that those coronaries, including the left main, is really low-lying and the height is really minimal. Look at this, the valve is in profile and look how low that left main, and it's a huge system. Again, here is the same thing. You get to appreciate now we're dealing with a complex degenerative MitraFlow valve. And again, this is the last picture. You get to appreciate that those coronaries are low-lying. We proceeded with heart team meeting and the patient was deemed frail for a redo surgical valve. And then we proceeded with a workup for TAVI. Hence, we went through the app. And if you know Metroflow valve, he has only 21 millimeter, which is a small valve. And on top of it, Metroflow valve has an externally mounted leaflet, which also contribute to the risk of coronary obstruction in this patient. Now we'll proceed with CT analysis, and from the CT scan, in those cases, you're gonna get all the information you need, and you can transform those details into the cath lab to make your procedure easy. So I used fluoro CT application to analyze his CT scan, and here in the first picture from the left, you can appreciate the valve perimeter is 72, and the maximum diameter of the valve was 24. This is an in-face view of the valve, which is understandable to be an areocranial. And once we move here to the left coronary and the right coronary height, they are always, we're going to isolate them in aleocranial view, and you get to appreciate the coronary height again, as we saw in the cath, is really low. So his left main was 5.9 and his RCA was around 9 millimeter. I want to draw your attention to the thickened leaflet here, which you can see it's an ugly thickened leaflet just in front of the left main. And in this picture here, the third picture, again, the thickened leaflet just lie in front of the RCA, and it's really above the RCA. So we get to understand the risk now. Let's talk about the coronary risk plane, CRB, which really what it comes to is the VTCs, valve to coronary distance. And you can appreciate here the left main, this is the virtual valve simulated, and the VTC is only 2.8, which is really low. And here you get to appreciate again, once we open the left main in a aleocranial view, again, that distance is really low, and the leaflet is just there, even above the takeoff of the left main. The same for the RCA. This is a simulated valve. The distance is borderline, is around 5. Usually it's safe, it's above 6. 4 to 6 is borderline, less than 4 is really a problem. But you get to understand here again the same thing, that the leaflet is taken, it's just above the valve. Now, the other thing we need from the CT scan is the new skirt plane, and the new skirt plane is the ST junction to the valve distance. And you can see here his ST junction height was only 18, and the maximum diameter is only 28. His sinuses were small, like hardly 25 by 25 by 28, which, and again, comes to the conclusion that his sinuses are small and there is a risk of sinus sequestration. So both his coronary risk plane and new skirt plane put him as a high risk for coronary occlusion. And hence, given all those risks, we planned to go for a TAVI with the coronary preventive measures. So for the left cusp, we decided to go with the basilica, bioprosthetic, or bioprosthetic scallop intervention laceration, or unicorn for the right cusp, which I'm gonna go into details a bit in a bit. So we used 21 MyVal in this case. And here we proceed with basilica for the left cusp. So basically we put 2 arterial access in the right side, the right femoral artery, 1 arterial access in the left femoral artery, which the valve went through the left femoral artery. And here for unicorn and basilica, you need to isolate the cusp fluoroscopically, which you can see here. We isolated the left cusp, and then you need to allocate the nadir of the cusp by using the TEE and small injection. So you use an AL3 catheter. You pierce the cusp with an Astato 40 wire stiff wire, but you really want to make sure you isolate the cusp, assign the nadir of the cusp, make sure on TEE and fluoroscopically with small injections that you're happy, and then you pierce the cusp, you put a 10 millimeter This is where we pierce the cusp. You put a 10 millimeter, which is this one, 10 millimeter single loop snare in the left ventricle outflow. So you can snare that wire back. And the wire, the stato wire, will put a flying V on it. So when it's gonna make your life easier when you want to lacerate the leaflet. So once you pierce the leaflet in the optimal spot, you snare the wire, you pull the snare and the wire back, and once you have your flying V ready, you just lacerate and lacerate the leaflet. So this is in a nutshell usually what we did for the left cusp basilica, and then more or less the same for the right cusp. For the right cusp, we did a unicorn, which is an electrocautery perforation of the leaflet. And then we ballooned, we perforated the right coronary cusp, and then we dilated with a 4O-NC balloon, and then we took a peripheral balloon, 12 millimeter, and then we ballooned the cusp open. And you can see here, you're gonna see a huge waist until the cusp lacerate. So once we open the right cusp, then the next step gonna be we'll proceed with TAVI. So that's the waist and then perforated. So the right cusp is lacerated. And then we went with the valve. That's the valve implantation at the desirable length. And you can see a waist in the valve. So we proceeded with valve fracture, where we used a 20 millimeter Atlas gold balloon at a high pressure, and we fractured the valve, and the hemodynamics post revealed an improved gradient across the valve, and even fluoroscopically, the valve looks better after the valve fracture. Finally, I want to show you the coronary intubation post valve, where you can see nicely how easy and the coronary intubation was. This is the left, and that's the right, and here is the left coronary artery. So that's in a nutshell how we did the procedure. Went fruitful despite its complex. With careful planning and all considerations, you can make it easier. Thank you so much. And if there are any questions, please let us know. All the best.
Beautiful, anticipating the complications and prophylactically preventing something happen. So beautiful. Any input?
Just a quick question. Why did you choose to do basilica and unicorn rather than just basilica for both or unicorn for both? I mean, it's fun and really good way. But why the combination?
Yeah, so basically, you're right. You can do both, like basilica in both.
Abdullah, can you go back slightly because we cannot see your face? I think just sit back. لا والله. Can you remove this? How can you guys remove his because we cannot see his face? You see, like
I think you need to go back a bit. Sit back.
Can you remove this the background? Can you do that? And talk. Keep talking. Well, yeah, keep talking.
1 second. So we could have done basilica basically for both, but we needed really to get a feeling for unicorn. But you're right, Dr. Mohammed. You can.
I mean, both are valid, and I'm just kind of curious because sometimes basilica might be a little difficult, but the fact that you were able to snare the wire and do it in the first one tells you. But yes. Because the radio frequency one makes it much easier, in fact.
Can I ask a question? Just from a patient selection point of view, what I noticed, the aortic valve area was 0.6 centimeters square, yet the gradient was in the mid-30s, though the ejection fraction is normal. I'm just trying to grasp the hemodynamics here. Can you explain that?
Yeah, so we find it's not uncommon, those with small ventricles, and on top of it, maybe I didn't mention it, he has a bit of AR. So that contributed to the volume, and that's why, especially if the technicians take the LVOT bigger, that's gonna affect the valve area, as we know. So there are really pitfalls. It's an excellent question, but I think the AR, the small ventricles, that would contribute to the final conclusion with underestimation of the really true LVOT diameter, because we square that to get the AV area, and probably that affected the whole picture.
But we do see this quite frequently, Hadi. And people, when
Yeah.
they go with the aortic valve area based on pressure, not pressure half time, but even if you move the cursor by like maybe 0.1 of a millimeter, you get a different number. So a lot of the time, and kind of deciding the treat to use TAVI is based on the cross-sectional area or the aortic valve area, which is a little less, because often even if you do direct measurement, you find the gradient not as bad.
Exactly. And sometimes even we can use the CT scan diameter, like the LVOT, if we have like a discrepancy. Sometimes we get extrapolate those data from the CT scan.
Yeah.
Thank you.
So thank you, Dr. Abdullah Ismaili. I think we should proceed with the next speaker, Dr. Mohammed Qantar, structural cardiologist from Hamad Heart Hospital in Doha, Qatar. And the case title is Fluoro-Guided Manta Rescue.
Assalamu alaikum wa rahmatullah. My name is Mohammed Qantar. I'm a structural interventional cardiologist at Hamad Heart Hospital in Doha, Qatar. And I was asked today to present a vascular complication with successful management. So today the case is a little bit advanced, and I hope we can all learn from it. And the title is Fluoroscopy Guided Rescue Manta Closure with Parallel Safety Wire After Perclose Failure. And I have no financial disclosures regarding this presentation. So in structural interventional cardiology, it's very important to know how to do large bore femoral access and how to close it. And the most commonly used way of closing a large bore access is normally using suture-mediated devices, which are normally percloses, are the most common ones. However, the perclose failure rate is not insignificant. In fact, in some studies, it's about 5%. In some other studies, it's all the way up to 9%. And this represents a challenge because when your perclose is not working, you are stuck with a large bore access that's probably bleeding. And your bailout options, there are many bailout options. One of them could be getting another femoral access and going up and over and trying to tamponade this large bore access with ballooning, potentially even adding a covered stent. You can call a vascular surgeon and they can do a cut down and primary repair. Manta, which is a collagen plug-based device, specifically designed for large bore access. It comes in two sizes, 14 French that can close up to 18 French, and 18 French Manta, which can close up to 22 French. Or if you still have your wire, obviously you can still do more percloses. But sometimes that's challenging with large bore bleeding access. Why is this case different? Because Manta is typically, by the instruction of use, is usually typically deployed after you have done your depth measurement with the special tool that comes with it. And usually they do not recommend keeping a parallel wire. In this particular case, and we will see why this is important, is we did the Manta as a bailout technique without knowing the depth up front. And in fact, we also left a safety wire because we didn't know if the Manta also fails. We still wanted to have the option of tamponading that vessel through the wire that's left in there. So our case is a 71-year-old gentleman who has a severe degenerative mitral regurgitation and underwent a successful but really complex mitral clip, M-tier, transcatheter edge-to-edge repair. And the reason why it was complex is his anatomy was not perfect for M-tier. We deployed 2 clips at the time. However, a few weeks later, when he was coming for a checkup echo, we realized there's only 1 clip. And when we did some investigation, we realized that the other clip had actually embolized into the renal artery. So our plan was to go large bore femoral arterial access for endovascular retrieval, obviously. And this case is going to focus only on the access and closure. We're not going to show you what we did, but we successfully retrieved the mitral clip. And when we wanted to do the closure, obviously we had done 1 pre-close, but on tightening the pre-close, when we were closing, the suture broke. And there was obviously 18 French sheath size right femoral artery access that's actively bleeding. Thankfully, we still had the wire in place. The patient, in fact, is morbidly obese. So his bailout techniques are all challenging, obviously. So getting another access quickly and going up and over is not ideal because you have another access to deal with. He's very obese. In fact, calling a surgeon was an option as well. But again, obese patient, actively bleeding. And we were very comfortable electing to do a MANTA. And we believe from our prior experiences is that MANTA actually works really, really well for obese patients. But the challenge with MANTA in obese patients is knowing the actual depth, like where is the depth of the femoral artery puncture that you have done. A lot of the times we actually do ultrasound depth assessment, but in this particular case, it was not doable because of the body habitus. So a unique strategy must be applied, and this is what we're presenting today for you. So I want to show you that our initial access was actually pretty good. We take a picture with the micropuncture sheath all the time, and we will show you how we did this. So usually when we get any access in the femoral, this is our routine, we actually save a fluoro save of the needle location. And we believe that this needle location can be a lifesaver. In fact, this was a lifesaver in this particular case. What we have done here is after the perclose had failed, we went back and we said, you know what? We know where our access is based on the needle location. And because we understand the MANTA device, we can actually, without knowing the actual depth of the femoral artery access, we can actually deploy it based on live fluoro deployment. So if you can see the lines, so the red line is the needle location where we are presuming our access is. The blue line, the faint blue line in the middle, corresponds to the distal edge of the actual sheath of the MANTA, and the green line is the second sheath where it houses the footplate of the MANTA. And you can see 2 arrows that represents, one arrow is the wire that the MANTA is being deployed on, and the other wire is actually a safety wire. In case the MANTA fails, we can actually advance an 18 French sheath over the other wire, and we would have hemostasis. So this was our technique. We have dual 035 super stiff Amplatz wires placed. The 18 French MANTA sheath was advanced over the primary wire. The parallel safety wire was intentionally maintained during deployment. And the saved needle puncture site was used as a fluoroscopic marker for deployment. And the deployment was done without knowing anything about the actual depth. And you can see using the other wire, we were actually able to take a picture after MANTA deployment, which is the second picture that's playing right now, with perfect hemostasis and no bleeding whatsoever. So this is our bear out sequence. We had a perclose failure. We maintained the wires. We used the needle location as a fluoro landmark. We deployed the manta using the second wire. We took an angio with a micropuncture sheath, and we confirmed hemostasis. And the final result was no extravasation, no dissection, and no pseudoaneurysm or vascular compromise. And again, I want to re-emphasize that this patient is morbidly obese. So getting a result like this with this particular angiogram here is phenomenal. And this is what we believe MANTA actually excels in this particular scenario where the patient is very obese. You can actually tell that we're pushing the abdomen very high here, to get access. And this is, again, the morbid obesity of the patient. So what we learned from this and what we learned from other cases, and this is what we advise everyone to do, is save and document the original needle puncture site during especially large bore access. We actually do it for every single femoral access. We believe even for venous access, we do believe it's useful sometimes. And the fluoroscopy can guide the rescue manta deployment when standard depth assessment was not available, or you were not actually planning on doing a manta, you were actually planning on doing percloses, but you can actually deploy the manta based on that location. A parallel safety wire may preserve bailout options, but requires careful deployment. The reason why MANTA does not endorse keeping a safety wire is because you can imagine when you are deploying the foot plate of the MANTA, it could actually get caught in the second wire. So you have to do it very carefully. And you can actually use the other wire. It doesn't have to be an 035 stiff wire. You can actually leave a micro puncture wire, which is an 018. You can leave a Grand Slam wire. You can use something, and you can use that to advance a stiff wire, or use a 4 French micro sheath over the safety wire to actually take a picture after the deployment of the MANTA. Because as you all know, when you deploy the MANTA, you actually lose access to the artery unless you have a safety wire. So the take-home message is large bore closure failure requires rapid and structured bailout planning. That's why you have in your mind to have practiced all of these scenarios with large bore closure failure, because you need to be quick and you need to, because these patients can bleed out very easily. So we propose to keep in your pocket this particular nifty deployment technique of the MANTA if you have MANTA in your lab, and we believe it's feasible and it's safe. The intentional preservation of a parallel safety wire can maintain bailout access and enable immediate angiographic confirmation. And this technique can actually be used, in fact, for normal MANTA deployment during routine large bore access, and I've done it multiple times in the past. Thank you very much for listening to this presentation, and I'm happy to take any questions if there's any. And you can also contact me on my email or other social media platforms. Thank you very much for having me.
يعطيك العافية دكتور محمد. Nice to see you with us.
الله يعافيك. شكرا جزيلا.
يعني in large bore access, the small details make the big difference. مهند شو رأيك؟
Yeah, absolutely. I just was going to say, if you're going to use a wire, it's probably a straight tip wire much easier than the J-tip one, because I've had this happen to me with I deployed 2 angioceal, because the MANTA is very similar to the angioceal in a way. It's just a larger thing, and the J-tip can get caught on the platform if you put it in the artery. But yes, it's about having the kind of thinking outside the box. MANTA is a good device, but it still has a failure rate up to 7 to 9%. So one has to be careful. Clearly, the guys are very experienced in using it, and that's very important.
Dr. Kantar, is this a Jordanian doctor, by the way? Is he
Am I a
with us?
Jordanian doctor?
No. The patient.
You might know the patient. This is HIPAA. We can't talk about it right now, but yeah,
No.
we can talk about it later.
No. I'm just, because one of my patients actually had the same scenario, and he came to me this past month. I just wanted to tell you he's doing wonderful, if he's the same person. But it's the same scenario, exactly.
I'm glad he's doing fine.
Yeah. يعطيكم العافية. Great. Okay, Musa Akbar, next one.
Next one is our before the last. We're glad to introduce Dr. Hadi Buhantaj, Senior Interventional Cardiologist from Amman, Jordan, who will give us his case presentation titled "A Chip Case Turning Sour After Success."
Good evening, my colleagues, and again, congratulations for the GIS for assembling us tonight to present our complications, and hopefully we can learn from each other in order to have a better outcome for our patients in the future. Let me share my case with you. This is a chip case which turned sour after successful PCI. After all of these wonderful cases which were presented my colleagues, and at the same time they had good outcome in spite of the difficulties, I thought there's nothing wrong with you a case which at times does not turn out to be exactly with the outcome we want. This is a 61-year-old male. He's a non-smoker with essential uncontrolled hypertension. He has hyperlipidemia with no diabetes mellitus. His past medical history is important because he had a deep venous thrombosis in one of his legs 15 years ago, and he was and is presently on warfarin. A heart cath was done before this PCI, which I will share with you, and the indication for it was a chronic coronary syndrome, in spite of maximum medical therapy not controlled, talking about angina not responding to maximum medical therapy. The cath was done 2 weeks prior to the PCI. It showed borderline left main and ostial circumflex disease. There was a 1-1-1 mid-LAD diagonal severe disease and normal large dominant right coronary artery. The ventricular systolic function is normal without significant valvular disease. So we had a heart team discussion, me, the surgeon, the anesthesia, and the family and the patient. And the family and the patient turned down the option of having coronary artery bypass surgery, and they requested a non-surgical approach. So I proceeded with right radial artery approach. This is a guide sitting in, it's an extra backup guide sitting in the left main coronary artery. You can appreciate that there is a distal left main disease, ostial circ disease, but it's not that significant. And you see here that the ostial circ has some disease, the ostial LAD, probably some disease, but the bifurcation in the LAD and the diagonal has a 1-1-1 severe disease. You will see it here in the right cranial view or cranial. You can appreciate the disease in the bifurcation here in the LAD. This is our target, of course. In the PA cranial, you appreciate the disease in the bifurcation, and you see a disease here, which belongs to the distal left main proximal LAD, but as I showed you in the other pictures, it did not seem to be of high significance. And this is a cranial view, and sometimes it overestimates that particular area stenosis. So I went ahead and did the dilatation of the main coronary artery after inserting 2 wires in the diagonal and the LAD. And I put a stent in, inflated it very well. And after the stent, I could appreciate that there is more of pinching and of the ostial LAD. I'm sorry, the ostial diagonal. So what I did, I intended to have a provisional type of approach from the beginning. So I did a pot, proximal optimization technique with a larger balloon. And after the pot, I put a drug coating balloon in the diagonal across the LAD and a balloon in the LAD. And I inflated both simultaneously with kissing balloon technique after each one was inflated individually. And I got these results. You can appreciate at the area involved, there's a well-opposed stent, the diagonal looks fine, and there is some disease in the distal left main and the bifurcation. Again, just to look at it again, you can see the trifurcation area with some disease, which does not appear to be severe. You always can overestimate it here with the tip of the wire here, and that what we did looks crisp, normally good, and with excellent result. And again, because I was worried about the trifurcation area, I took more pictures, and I was comfortable that the distal left main, ostial LAD, and ostial circ do not have a severe disease that I have to address at that particular point. You can appreciate here in the PA caudal steep view the ostial circumflex disease. So at that point, I decided to stop. I did an ACT, which I always do before I pull the radial sheet, and it was therapeutic. We pulled the radial sheet, sent the patient to the coronary care unit under monitoring. My plan for the future was to see how the patient does clinically, and maybe later we can interrogate the trifurcation area at the distal left main with an iris, keeping in mind that the patient financial situation did not allow to do that during this procedure. So the patient went to the coronary care unit, and in the coronary care unit, initially he did wonderful. He had no symptoms. The site of the cath was perfect. And the ECG after the PCI was completely normal. And all of a sudden, minutes later, he complained to the nurse that he had chest pain. The nurse and the doctor in the CCU noticed extensive ST elevation on the monitor. And while just trying to interrogate the patient and talk to him, he arrested. And according to what I was told, he became pulseless. His breathing became sluggish. They had to start CPR, intubate him, and they called upon me to come and help. So when I came in, they were doing CPR in the CCU. The ST elevation, when they stop the CPI, it can be seen in the monitor very clearly. So I asked everybody to clear the pathway for me to go back to the cath lab. We went to the cath lab while the CPR is going. I called the cardiovascular surgeon, and the first thing I did while they were doing CPR, I accessed the right femoral artery, and I did a quick echo, which did not show a tamponade. I did an ACT very quickly, and it was about 200. So I proceeded with an angiogram while the CPR is going. You can see that the coronary flow was still there, not as brisk, especially in the mid-LAD. And after I did wire the vessel, did balloon angioplasties all along, made sure the ACT is high. The surgeon was coming in, and I had the balloon pump on standby, and I called for the ECMO to be ready. And unfortunately, we continued doing CPR, and in spite of retaining the flow in the coronaries, I could not revive the patient out of the collapse he got. We tried, we kept trying. And unfortunately, in spite of all what we did, the outcome of the patient was not good, and we had to stop the CPR to this unfortunate ending. Colleagues, I wanted to share this with you. It's a sobering experience for any interventional cardiologist to have a cardiovascular collapse during PCI or immediately after. What's more difficult and more sobering is when you do not know exactly what happened which led to this disaster. I'm open to hear from you, your suggestions, your suggested approach, if any, is different, and I will be happy to discuss that with you. Again, thank you very much.
Just the outcome is really going through this. We've been, I think every one of us been through sometime like this cases, and we don't know the answer. We've done everything right according to what we know and our experience, but sometimes we don't know answer. I'd like everyone's input here. I think we all been through this. Muhammad.
Yes, very interesting. Can I ask you, when you took him to the lab, I mean, I suppose with CPR is difficult, but has the ST changed by then?
Well, you can imagine, Muhammad, the whole time they were pumping on his chest while I'm doing the cath, actually.
Yeah. No, just because I've seen one case that happened in the lab where acute thrombosis and do the CPR, when you repeat the thing, the thrombus has been created distally. Because ST elevation happens when you block something and, you have ischemia. And sometimes with the CPR, and this has happened to me once, I've seen it once, and vigorous whatever it is, the thrombus that was there when you take in the picture, when you repeated it after everything else, the thrombus is gone. And I just wonder whether that's what happened in this man. Because what's the explanation for ST elevation? And because I was thinking to myself, are you going to find that the left main has got a problem because you've gone through it? Because it does look significant, but I could appreciate what you said about IVUS, etc. But yeah, so I don't know. Very, very interesting.
Well, the reason I shared it with you guys is just because sometimes you face those issues, you try your best.
Yeah.
It definitely spoils your whole month that month, just when it happens. And you look at the film again and again and again. I shared with you just some pictures, actually, but there are tons of pictures there in the CD. And then you don't understand what happens. If he had thrombosis in the artery, let's assume it's an acute stent thrombosis. Okay, fine. I mean, from what I gathered, he was in the CCU. They immediately acted upon it. He was given another bolus of heparin immediately. CPR was done. He was taken to the cath lab. I mean, why would he have this disastrous outcome, even if he had a super acute stent thrombosis, But because of the history of the DVT, it made me wonder, maybe he had a hypercoag state or something, which might put him at more danger. So, but we face those, and it's sometimes good for it to happen to us so that we don't feel we are the gods on earth, because it reminds us that sometimes we cannot help it.
Yeah. No, it's always a very difficult experience because you go in wanting to do your best, and your main thing is do no harm, and you think you're doing the best thing. And something like this, it is baffling that you can't. It's no explanation, but it's very difficult. But we've all been there, and you do your best, and this is the main thing, and so which is very interesting. And I would like to all the audience who's listening, particularly the junior guys, to listen to what Dr. Abu Hantash has said. You go back and you look. Because everything wrong happens, you go back and you look, did I do something? Because this is important. You can't just accept, oh, fine, this happens, and you walk away. You learn from every single case. Go back and look, because sometimes even the slightest of things that you have done, you think, okay, maybe this is the case. So you learn from it to go. Don't just ignore it and walk away.
Totally agree.
Great. So thank you very much, Hadi, for sharing that one. I think, always the complications is nuts. Is to be prepared. We all agree to that, to recognize it, and you do your best. Of course, if you're not prepared, that you'll be blamed. But if you're prepared, you do your best, and then the results, sometimes it's not what you want. But thank you very much for sharing that one. Now let's go to the one who always jump in when you have nobody to speak. We had the speaker for the symposium, but that had to apologize. Then Musa Akbar Habibna jump in, and his topic symposium about imaging using IVUS, Focus IVUS PCI, Musa Akbar, and sponsored by Boston. Yes.
Yeah, when somebody apologizes, they get the things on me. So to help them, thank you very much, everybody. I promise to finish, inshallah, on time or before the time. So the talk, Fawaz gave a talk on the OCT. Now I'll just give you the image-guided PCI with the new insights from the IVUS recent clinical trials. These are my disclosure, and just to get the laser pointer. Good. So why we need IVUS? Why we need imaging? Because disease complexity requires improved imaging. You know, angiography has limitation, but in the images give you a better understanding and better understanding in the ways of the 3, 1, 2, 3, to see, to prepare, and to treat. And to see is the extent, the type of the disease, prepare the type of the lesion to need the modification, debulking, and then you treat when you IVUS confirm the stent deployment with a good opposition and a well expansion. The guidelines, the recent guidelines have been classed as the imaging IVUS or ACT. This is the European and Chronic Angina in 2024. Is recommended for performing PCI in the complex lesion, particularly left main, true bifurcation, and long lesion. And this is class 1 with level evidence of A based on multiple randomized trial. The US last year guidelines for acute coronary syndrome has also mentioned on the imaging required for left main complex lesion, and either IVUS or ACT is recommended for the procedural guidance to reduce the ischemic events. Again, similar like European class of evidence 1 with level of class 1 and level of evidence is A. Now, we know FFR is also important for physiology. FFR will tell us if this is physiologically significant with significant ischemia, need interference, but physiology does not tell you how to treat the patient based on morphology. Is this lesion is only lipidic or fibrotic or calcific? And there are differences, particularly the calcification. Need if it's the extent, the type, superficial deep, to need debulking or modification of calcification. So physiology also has limitation, but we believe that the physiology and imaging, particularly the IVUS here, are complementary in better understanding the lesion and better to modify it and treat it. Now let's talk about clinical data trials. There are 4 I presented very shortly. There is IVUS Expel for long lesion, and there is Ultimate for all comer, Renovate for left main, and then an IVUS in acute coronary syndrome. So the IVUS XBL in the long lesion, this is a Korean study in 20 center, 700 patient underwent IVUS versus 700 angiography. The primary endpoint is a MACE at 1 year. These are the baseline, no much difference between 2 arms. And at 1 year, the patient with the long lesion, the IVUS guided PCI showing resulted in a significantly lower MACE than the angiography guided PCI. The differences in these events were translated into 48% relative risk reduction with significant p-value favoring the IVUS over the angiographic guided PCI. So the ultimate is for all comers. This is a Chinese study. 724 underwent IVUS, angiography similar number. The primary endpoint is target vessel failure at 1 year, and all comers means their long lesion, left main, multivessels to stent bifurcation, chronic total occlusion, moderate to severe calcium. And it showed similar to IVUS XPL that at 1 year, at the all comers, the IVUS guided PCI has the lower percentage of target vessel failure compared to angiographic guided PCI at 1 year. That's the difference translated into 47% a relative risk reduction, again with significant p-value at 1 year. And the next one is Renovate IVUS for complex lesion. This is a South Korean study making imaging vessels, imaging based vessels. Majority are IVUS, 75%, OCT 25%, taking 1,092 patients versus angiography 457. In complex lesion, define the complex in the lesion length, unprotected left main, multivessel, true bifurcation, severe calcium, instant restenosis, and osteal and diffuse disease. Again, similar to the previous two trials, the patient with complex lesion, the imaging guided PCI, OCT and IVUS, having lower target vessel failure at 2 years compared with angiography guided PCI. The difference is translated into 36% relative risk reduction with early separation of the curve with significant p-value. The last one is the IVUS in acute coronary syndrome. This is a trial, multi-center, multinational, Chinese, Italian, Pakistan, and UK. Mainly IVUS, 1,753 patients with 1,750 in angiography. Primary endpoint in 1 year, target vessel failure. Of the acute coronary syndrome, you dissected unstable angina majority, almost 40%, followed non-ST elevation MI and STEMI elevation MI. More like the 3 previous trials that I have mentioned, that the patient with acute coronary syndrome, the IVUS guided PCI have lower in target vessel failure at 1 year compared to angiography guided PCI. That difference in number translated into 45% relative risk reduction with a significant p-value. And therefore, putting all the trials, the IVUS XPL for long lesion, Ultimate for all-comer, Renovate for complex lesion, and acute coronary syndrome, you will see a persistent and consistent benefit of IVUS guidance compared to angiography-guided PCI in these 4 trials in terms of MACE for the next one, but the 3 trials all target vessel failure, which is lower with the IVUS guided PCI. The other important things in these 4 trials, when they analyzed the IVUS XPL Ultimate Renovate, they compare the suboptimal with optimal IVUS at 1 year in the target vessel failure. Of course, when you achieve optimal IVUS, you will have the lowest target failure. But when you're not doing optimal, i.e. suboptimal, the results are more equal to angiographically guided PCI. And for the very important to optimization, you take into consideration the criteria, which is the minimum stent area more than 5 or 90% of minimum luminal area, distal reference, the plaque burden, less than 50 at the stent edge and no edge dissection. But further to the optimization of a stent, not only in the post-stent, but also important in the pre-stent to approach the optimal IVUS and therefore to get the lowest target vessel failure. Again, 1, 2, 3. The 1 is the lesion length from the landing zone, from normal healthy area landing zone to healthy area, and the plaque morphology, whether it's a lipid, fibrotic or calcified or mixed, to use the type of modification, and finally the vessel size to use the proper stent size to avoid malapposition and proper stent expansion. For the post-stent, as a part of optimization, you need again 1, 2, 3, avoiding the geographical miss, as well as the avoiding the edge dissection. And then checking the malapposition, you need for post-stent proper apposition and also expansion of more than 90, and expansion as is important as a proper opposition, because the studies showed that when you under expand the stent less than 90, there is a great chances of developing a stent thrombosis. Is really IVUS is cost effective compared to angiography guided? There is Italian study, Australian, UK study, and South Korean, particularly the South Korean analyze their data now, their data showing that it is a cost effective in the blue dotted line is image PCI. Initially is expensive, but as the time goes on long term, there is a cost effective owing to the less target vessel failure, requiring less rehospitalization and repeated revascularization, and that favoring as a cost effective in the long term. I present three, then we will show the meta-analysis, and then we'll conclude. This is IVUS CHIP trial. It's a European, presented in the last ACC 2026 in March in New Orleans, Louisiana, taking a patient, 110 patient for IVUS, and geographically 1009. Just keep a note, the angiographic LV calcification in the IVUS group angiography was 45.8, and it showed the results that there is a neutral without separation, as on the 4 trials I showed you, favoring the IVUS over angiographically. And why is that? It is because in angiographic LV calcification, there is a low use of calcium modification techniques. The rotor ablation was 6.5. The ultrasound was 10.6, and orbital is 2 points. So low use of calcium modification is one of the explanations. The other, look for the pre-PCI, the low usage of the pre. As we said, to get optimization, you need pre-stent and post-stent, and even though of the post-stent is also low, and for this reason all contributed to the not a separation of both lines or both curve of IVUS guided versus angiographically guided. So the need for high need for optimization, this is a panel discussion in ACC, that you need for optimization pre and post, as well as better modification to show any separation of these curve. The other trial that presented in ACC 2026 in New Orleans is optimal left main, unprotected left main. Again, similar overlapping curve, neutral, no significant. And the reason is this: low use again for a pre-PCI, and 73 only optimized. The suboptimal was almost 28%. And for that reason, the pre-use of the PCI, pre-PCI and post-PCI, not high, all contributed to the overlapping curve. The other things is that the IVUS people who did these trials, they are very expert operators, so they rely heavily on the angio, what is called contamination bias in angio recalibration, that they're doing the measurement, the eyeball measurement rather than imaging measurement. The last of this trial is DK Crush, the Chinese, and you can see the difference from ultimate. Look to the pre-PCI use, PCI use of IVUS 98, the post-optimal PCI 75, and that causes the superiority of IVUS in reducing target vessel failure compared to the angiographic guided PCI with significant p-value. However, when the dead suboptimal PCI compared to angiographically, there are similar results, i.e., if your results is suboptimal, you will end up with same as angiographic outcome. When you do full PCI guided strategy, you will have the superior outcome with the lowest target vessel failure revascularization. My last is the meta-analysis to overall of these trials. This is the Greg Stone meta-analysis in the Lancet, published in 2024, and they used the target vessel failure with subtracted in all these fragments, more than an IVUS 13 randomized trial, an OCT 10, and they did this analysis showing in all parameters they were reduced with image-guided PCI with their OCTI IVUS compared with angiographically guided PCI. And this is summary of the meta-analysis. that the image guided, whether OCT or IVUS, reduced target lesion failure by 31%. That is driven by 46% of cardiac death, and target vessel MI 20%, target lesion revascularization 29%. A huge difference in stent thrombosis, reduced in image 52%, all MI 18, and all causes 25. A very important conclusion, ladies and gentlemen, that the outcomes were similar for OCT guided PCR or IVUS guided PCI. In last 1 minute, I'll just show you the Avigo Plus machine on the IVUS. This is the third generation, the first Polaris. The second generation is Avigo 2. This is the latest, and there will be more latest generation will be presented near of the end of this year or beginning of next year. It's a two-type mobile cart or integrated system in the lab, and it has key features. It's a high resolution HD high definition resolution with 60 megahertz, giving high resolution with this pullback speed, automated pullback speed with 8 speed, and have the feature of AI, artificial intelligence integrated, which is called automated lesion assessment. And that automated lesion assessment give you the lesion length, the size of the vessel automated and in a second rather than manually, and the minimum lesion. And in the later future device, they will have automated stent assessment, where they give you the stent expansion, again automated, and that will help in the post-stent, as well as automated lesion help in the pre-stent area. I think this is my last slide, and thank you very much for your attention.
Outstanding, Habibi. يعطيك العافية. Thank you very much. Let me get this. Okay, let's see how we can. Okay, let's go to that. Okay, thank you very much, everyone. Input here. If anybody has got a comment on this, but maybe PCI using imaging, but my question related to the complications. I know it's very rare to get complications with using imaging, but for me, because imaging is I see it mainly used in the conferences and sometimes to show. But so I think one of the complication I can say with the imaging is poor preparation of the imaging tools itself, and then the inappropriate interpretation of it and inappropriate using of it. I don't know, anybody got comment on? I mean, we all know about how important imaging is and as class 1A, but the problem is all what I said about the complication.
I just wanted to say something. For the optimal study, which was presented in the ACC, the reason it did not show major advantage, I think you have to think about it this way. For operators who use imaging like IVUS a lot, if they don't have IVUS in the cath lab, they have something which I call the IVUS eyes.
Yeah.
They have the eyes of somebody who is using IVUS. Why do I say that? If you're using IVUS a lot, you will never put a left main stent of 3.5 and leave it like that. You will never do that in your life, because it's going to be a lot bigger. It's the same thing for ostial LAD, ostial circ, especially in males. So you still can get away without IVUS, but if you didn't use IVUS before, you will always do undersizing along the way. That's the way I see it.
That's what they call it, the angio recalibration in their comments. They were very expert in IVUS, and then they use only their angio as a recalibration without using the imaging.
So that's absolutely correct, because you build the experience looking at the angio based on the IVUS, but you do not have to use it all the time.
Yes.
And the reason why I think IVUS studies are very positive for IVUS is because of the sizing. This is the majority of the time. The undersizing of stent is our Achilles and our biggest problem. And had you mentioned about the left main, when you go to 3.5 or 3.0, then you post dilate it, it's never the case. If you size correctly, you're always going to have a much better outcome. The good thing nowadays, of course, the stent are fantastic. They perform very well. So not every undersized or under expanded stent is going to cause a problem. However, every time I have a problem with the stent, it's always undersized or under expanded. So this is where the IVAS teaches you how to kind of size correctly and do the proper, deployment. If you put a 3O and a 4O vessel, inevitably it's gonna block off, it's gonna reach sinus. So this is where the imaging comes in. But yeah, you don't have to use it in every case. And we have to be realistic. I'm privileged, and a lot of us work in a place where you can use IVAS as much as you want, but there's a lot of everywhere around the world. That is not an easy thing to do because the patient will have to pay for it, and it's not something that's affordable.
It should be reserved for those we need to optimize, for those we need to prevent the anticipated complication.
Absolutely right. Khalid bin Thani, anything to say?
I will add here just what Dr. Mohanad and Dr. Hadi they add. I mean, they alluded basically. It's a privilege, and who's going to pay for it, especially in the private sector, is the patient himself. So you have to select your cases. You have to decide what kind of modality. And I think Dr. Hadi, what he said regarding the IVAS eye, I do agree. I mean, a hazy looking after a stenting, stent edge, you would think it is a dissection. Maybe you didn't need to go and do like, an IVAS, just to stent that edge and that's it. I do agree that at the end of the day, individualization for the cases is very important.
Of course, and the use of the imaging and complications when we have no reflow, we have loss equipment. So it is important, guys. You've been so energetic. We are 1 hour and half and 1 hour and a half, beyond our time. I think the discussion really made this the beauty of this meeting. So the complications, we all agree, is going to be part of our life. And some people say it's inevitable, but I think with the great preparation, anticipation, cognition, and learning from it, I think that will come down. We don't say okay, it's coming down, inshallah. But I know that the more complication you do, you are expected to. But as you see in the last case, it's despite everything you do, okay, that will happen. But that and how to come out of it, I think Hadi nicely shared with us. I think his beauty is not just the case itself, how to handle this yourself, looking after yourself. You are a human being at the end of the day. So the complication, we learn that to anticipate, recognize, respond properly, of course, and to be honest, and then learn from it. And I think that's, if you can do that, and people who are attending this meeting tonight go with that kind of every case, I think will be happy. So thank you very much, all of you, all the nice cases you shared with us. I hope those who are attending as well learn something for tomorrow. And then we'd like to see more version of the physical, inshallah, in Bahrain, all of you. So thank ICOM, thank the sponsors, thank every one of you, and Jazakum Allah khair, and good night.
Thank you very much, and nice to see you all. See you soon. Thank you
very much for everybody. Thank you.
Brilliant
Dr.
work,
Ali,
guys. Thank you for
Mohanad,
your effort.
all the Khalid, thank you very much.
Bye-bye.
Thank you very much. Bye-bye.